Namaste. Please join this Sunday on a free global online. Namaste. Please join us this Sunday on a free global online episode, Mental Health Awareness.
Stars, they can tell you stories which are brighter than yesterday. The streets have never been so quiet. The squirrels found a new hideaway. Tomorrow will never be the same. There is so much hope in our hearts. Brick by brick, we shall.
Gentlemen, may I have your attention, please? The show starts in 9, 8, 7, 6, 5, 4, 3, 2.
Global Namaste. Good morning, good afternoon, and good evening to all the viewers of Healing Our Earth. I'm your host, Amrita Sharma, and I welcome you to this episode of Mental Health Awareness. In today's episode, we'll be talking about something interesting and also shedding some light on the mental health. Mental health has been a great issue of today. Few years ago, this wasn't a story, but now it's every house story as well. And that's why today's episode is on mental health awareness. So, to talk more about it, we will have more chit chats with our guests and panelists whom we have invited for today's episode. But before that, to build mental resilience, it's very important to believe in something, to believe in the supreme power, and to have faith in the existence because of which we are here. And that's why I'm going to chant Gayatri Mantra. You can hold any affirmation of your choice. Bringing the silence within yourself with a calm mind, taking a deep breath inside. Let's chant Om Om Bhurbhuva Swaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yo Na Prachodaya Om Swaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yo Na Prachodaya Om Bhurbhuva Swaha Tatsaviturvarenyam Bhargo Devasya Dhimahi Dhiyo Yo Na Prachodaya Om Shanti Shanti Shanti. Welcome. Mental health, that has been one of the grave issues of today. It is very important to think about how to build that mental resilience, how to strengthen ourselves, what are our thoughts, why does my mind think like that? And that is why to build that mental resilience, to have awareness about your thought processes, and to prevent the big mental diseases that have taken up a big space in our lives and the community, we have this episode of today. And for this, I'm very glad to invite the episode producer of today, Kirit Mistry. Global Namaste to you, Kirit Mistry. He is our organ donation lead and also one of the leads of South Asian Health Action. And that is why we have with him a lot of episodes in relation to health, and he is the one who will be guiding us in light of what best can be done for mental health. As we move to our guests, let's welcome. Good afternoon and Global Namaste once again.
Global Namaste, Amrita ji, and thank you for the kind introduction, and really great to be co-hosting this with you as well, because we've got a very great program lined up with some eminent speakers, presenters who are doing some fantastic work. And this topic for today and this week has been mental health awareness in the UK. So it's been a week. Today's the last day. And the theme really is about celebrating community and community power. And today's presenters have all been doing some fantastic work in the UK and in India and globally around bringing communities together and most importantly, we still have a lot of stigma and taboo around mental health within our communities that we need to have more conversations. So I'm really excited for today, and also I'll also share some work we've been doing around mental health. And as you know, my background is in drug and alcohol addiction, and I've worked in mental health and now more in health promotion. So really great to be here as part of the Healing Our Earth family as well.
Wonderful.
And it's
So
great
please
to
welcome our first guest. Yes.
so it's great to have Guru Krishma, who I met recently, who's an Oxford doing her master's or PhD, sorry, and most importantly, she's doing some fantastic work, not just in the UK but in India, and also hails from Canada as well. So we've got her giving us some really insights into work she's been doing and also what she's trying to do here in the UK. So without further ado, I'm going to give the floor to Karishma to just again, I've not done justice to present your, accolade and also your CV. So just give our list of viewers a bit of background so that they can hear it from yourself.
Absolutely. Well, first off, thank you so much, Amrita, for the lovely chant. It was beautiful. I think a beautiful way to start
Thank
off
you.
the event. And thank you for the introduction, Kirit. It was quite close to being spot on. So hello, everybody. Good morning, good afternoon. I know we have individuals from all over the world joining today, so thank you for joining. My name is Guru Krishma Dhillon. I'm currently a student researcher at the University of Oxford. I'm based in Oxford, and most of my work is focused around the PRAM project in the United Kingdom. My supervisor, Dr. Nicole Vichupa, who will also be speaking today, she leads the project in India, and she does amazing work there. But my project is more focused on the United Kingdom. So I can maybe share my screen, and we can get this started. Okay. Can I just confirm everybody can see my screen?
Perfect. Please go ahead.
Okay, lovely. So I've done a brief introduction already, but as mentioned, today I will be sharing my master's research project, which is titled PRAM UK. PRAM stands for Perinatal and Mental Health Project, and this work is focused on understanding the experiences, needs, and barriers faced by South Asian women in accessing perinatal mental health services in the United Kingdom. As mentioned, currently being supervised by Dr. Nicole Vichupa and Dr. Jennifer McClellan. And this work is in partner under the University of Oxford, in particular the Newfield Department of Women's and Reproductive Health. So getting into this, what exactly is perinatal mental health? So perinatal mental illnesses are defined as mental illnesses that affect females during the perinatal period. Now, a follow-up question from that, what is the perinatal period? Well, the perinatal period is the time from when a woman becomes pregnant up until 1 year after childbirth. So this encompasses both the antenatal period, meaning before birth, so one's pregnancy, as well as the postnatal period. And it is truly a critical time period for both the mother's and the baby's health and overall well-being. Perinatal mental illnesses can range from mild to severe and include anxiety, OCD, obsessive compulsive disorder, post-traumatic stress disorder, PTSD, and eating disorders, as well as a plethora of other illnesses. And if left untreated, can have significant and long-lasting effects on women, the child, and their wider family. So when looking at some of the statistics surrounding perinatal mental health in the United Kingdom, we know that women are 22 times more likely to have a psychiatric admission in the month following birth than in the pre-pregnancy period as a whole. So we can tell from this that women are extremely susceptible to the onset of perinatal mental health or mental health challenges during this period, which is why it is such a critical time point to ensure that women are accessing the support that they need. In addition, we know that perinatal mental illnesses affect up to 27% of new and expectant moms, and this is almost 1 in 3. So this is an extremely large proportion of women who are giving birth that are affected by this. And lastly, UK primary care data has reported that the proportion of children exposed to maternal mental illness has increased from 22.2% between 2005 and 2007 to 25.1% between 2015 and 2017. So this is something that is on the rise. Now, when looking at this data, one question that I'm sure many of you may have, and it's something that I definitely had, is what are the experiences of minority women? We know that women as a group are often largely or underrepresented in health literature, and even more so are individuals from minority groups, in particular ethnic minority groups. And when looking at ethnic minorities, what were the experiences of South Asian women? And that's kind of what drove this research project. So what do we know about South Asian women in the United Kingdom? We know that British South Asian women are the largest ethnic minority group in the UK. So they constitute a large proportion of the population in the United Kingdom. We also know that individuals from South Asian ethnic groups have an increased likelihood of experiencing adverse maternity outcomes, including a 2 to 4 times higher risk of maternal death. And lastly, we also know that British South Asian women are statistically more likely to experience mental health issues. However, they present to mental health services at a considerably lower rate than white women. So I think two main problems stick out here. A is that these women they do have a larger risk of experiencing mental health challenges. And when we look at the perinatal period in a time period that they're also, by other data, they're more susceptible to developing these illnesses, as well as they are less likely to access support. So this puts them in a very dangerous and harmful situation. And with this, there's a clear and urgent need for a continued and focused action to address these disparities and address this treatment gap by providing better support to South Asian women in the perinatal period. So with this information in mind, we sought out to answer the research question, what are the experiences, needs, and barriers of South Asian women with perinatal mental health problems in the United Kingdom? And this is essentially the PRAM UK project. So with this research, we really have 4 main objectives and areas that we want to shed more light on. The first of this is understanding descriptions and perceptions of mental health in South Asian communities. And this is something that I'll be touching on later. However, oftentimes in these communities, there's a language barrier, and it's not only hard for women to express their emotions or their feelings due to this barrier, but also due to the fact that there's a lack of terminology in their native language to express these Western clinical terms. So understanding what concepts, what ideologies, what alternate ways of describing these concepts of depression, anxiety, of perinatal mental health illnesses, what is being used, so that we can better understand these women when they come in to share these with their healthcare provider and perhaps also aid in early detection of perinatal mental health illnesses. Next, we hope to understand what some of the barriers are. So we know that South Asian women are definitely much less likely to access services for their mental health challenges. So understanding what the unique barriers are that prevent them from accessing these services so that we can hopefully aim to create change on a more systemic level and hopefully mitigate these barriers in the future. Number 3 is needs. So while we do gain this better understanding, we also hope to center South Asian women's voices and understand what they think they need and what they think would best help them in the future, if they were to perhaps experience these challenges again, or for the community as a whole, as individuals who have lived experiences of mental health challenges, what do they think is best and what do they think are the next steps? And lastly, what are the social determinants of health? So we hope to identify any of the relevant social determinants of health that come to play and that affect South Asian women during the perinatal period and their mental health as a whole. So with these objectives in mind, we decided to start off by conducting a scoping review, so a review of the literature that was out there in order to gain a more comprehensive understanding of the topic at large. So we sought out the question, what is known about the experiences of South Asian women who experience perinatal mental health challenges in the United Kingdom? And with this, we searched 5 databases, and those were Medline, PsycInfo, Embase, CINAHL, and Scopus. And we had some inclusion and exclusion criteria. So our inclusion criteria was studies that were conducted first and foremost in the United Kingdom, as well as had to do with South Asian women's experiences with their mental health challenges, and in particular during the perinatal period. And exclusion criteria included studies that perhaps talked about ethnic minorities, women's experiences as a whole, but didn't necessarily distinguish those from the experiences of South Asian women. And we want to ensure that we're really just capturing the experiences of South Asian women, as we recognize that different ethnic minority groups do have different unique cultural, social factors that come to play, as well as studies conducted outside of the UK. And lastly, studies that looked at mental health more generally as opposed to perinatal mental health. So with this, we were able to get 590 results from our database search, as well as we also searched some Grey literature databases and also did some snowballing. And we ended up, after 2 rounds of screening with our inclusion and exclusion criteria, there were a final 37 studies included in this scoping review. And with this, we are currently in the data analysis phase. However, I do think it's important to share some of the preliminary findings that we have, as they offer some insight onto the future directions that we hope to take. So one of the most pervasive and most prominent, I want to say, themes that came up within the literature was that of stigma. And many studies highlight that mental health issues are often seen as a sign of weakness or inadequacy, especially in South Asian cultures where women are expected to maintain strong maternal roles. In addition, South Asian women described a strong fear of being negatively judged by the community and family members for having mental health or for experiencing mental health challenges. And lastly, women feared the consequences of disclosing mental health difficulties, such as social isolation. For example, one woman said, in my ethnic background, and she was Bangladeshi, she said they don't really understand it very much. They just think that you're crazy, that she's just gone crazy or loopy, and that's the idea they have about it, especially being in a hospital. So when we see the terminology used here, crazy, loopy, we can kind of understand just from this quote, the stigma around concepts of mental health and them being seen as an individual being deemed as crazy for experiencing these challenges. And this is just one of many that came up in the literature. Next, another extremely prominent theme was that of language barriers. And this definitely led to fear and mistrust in healthcare systems and in healthcare services. So South Asian women reported difficulties in communicating their symptoms with their healthcare providers. And when we think of providing optimal care to individuals, if there's no communication, if women don't feel that they're able to express what they're feeling, then this definitely erodes this quality and the standard of care. And as mentioned, during this critical time period, this can be extremely dangerous. In addition, Asian women felt they encountered significant barriers to obtaining translators. So not only did they feel that they couldn't communicate their symptoms, when they tried to seek out support from translators, they weren't always readily accessible. And this often led to alternate ways of translating, such as a family member or someone else close in their circle. And this often had other implications in terms of privacy and allowing for expression of open communication of how they were feeling. And lastly, across different ethnic communities, women reported not having a term for perinatal mental health in their language. And as a result, women often lack the terminology to describe their symptoms to families and their health professionals. So we can imagine in a system where individuals are already struggling to articulate in a different language, perhaps from Hindi or Punjabi or Bengali to English, they also don't feel that they have the terminology in their native language to express this. So this definitely creates a complex system of barriers. For example, one woman said, sometimes when you have a baby, a woman comes from the hospital and we don't understand what they say. And she's referring to midwives. We just sit there staring at their faces. And lastly, another extremely important theme that was prevalent in the literature is that of discrimination. So women describe being met in previous encounters with the healthcare system with the lack of cultural awareness. They had been discriminated against or judged on the basis of their ethnicity and culture and reported negative experiences in relation to their ethnicity, leading to having negative perceptions of the NHS as a system as a whole. they reported being fearful of or actually being discriminated against by healthcare services, both because of being Asian and having postnatal depression. So these women come in at perhaps some of the lowest points of their life, and essentially they still feel that they're discriminated against when they're trying to seek out help. One woman said, I got answers from professionals like, there is nothing wrong with you. Go back home. Stop disturbing us. Basically, you are wasting our time, and they were horrible. So from these three themes highlighted in our preliminary findings, we can understand that there's definitely a lot more that needs to be known and that needs to be explored about South Asian women's experiences in order to create interventions, to create systems that serve them in a more optimal way. So moving on from this, we hope to, from these findings that we've essentially uncovered from the literature review, from the scoping review, we hope to conduct a qualitative study. And I'll just be sharing a little bit about the empirical methodology. And we hope to interview three main groups of women, or of individuals, mainly women. So group one will be from a preventative lens. And in group one, we hope to understand the experiences of unmarried or newly married South Asian women who have had previous experiences of mental health challenges. So although they haven't embarked on their pregnancy journey yet, or perhaps they're not married, due to their previous experiences with mental health, we hope that we can gain some insight on things that they may feel would help them when they do choose to become pregnant or when they do choose to embark on that journey, and understand from a preventative lens as members of the community what they think would be best. In addition, we also have group two, which is more of an informative lens. And these are South Asian women self-identifying as having experiences with perinatal mental health illnesses. So these are the women who have lived experiences during their pregnancy, during the perinatal period of mental health challenges or illnesses as a whole. And we hope to understand what their experiences were in terms of help seeking, in terms of being individuals of the community, and having mental health illnesses, and how those intersected and shaped their experiences. And lastly, group three is also an informative approach, and we hope to understand the perspectives of family members, carers, charity workers, healthcare workers, or community leaders who have had experience working with South Asian women who have had perinatal mental health illnesses. So overall, understanding from a third-party view, how can we best support these women, and understanding what their experiences are, maybe with helping these women navigate the healthcare system or helping these women within the community as a whole. So we have two main modes of, or we hope to employ two main modes of primary data collection. The first will be focus group discussions, and this will consist of groups of 5 to 7 women, and they will occur in private and in a non-judgmental manner. And we hope to understand more about their experiences, in particular women from groups 1 and 2. And in attempts to make this study more accessible, we hope and we will be employing these interviews in English, Hindi, and Punjabi based on the language of preference of the women who are recruited. As well, we also will be conducting individual interviews for individuals from group 3, which are, as mentioned, healthcare workers, community leaders, family members, and carers, also conducted in English, Hindi, or Punjabi based on their language of preference. And one theme that we hope to weave throughout this entire study is that of adopting community-centered approach. So we have reached out to several charities such as South Asian Health Action, and Kirit has been very helpful, as well as Therapy. And these charities have experience of working with the community and working with individuals, women in particular, who have had perinatal mental health illnesses. And we hope to use their expertise to ensure that this methodology and the study design is conducted and has been synthesized in a way that the study can really best serve and best understand South Asian women in a way that is best for them. So we have actively been ensuring that we are engaging with these communities in the best way that we possibly can. I've also attached some other photos. On the left is a photo. Early in November, I had the opportunity to speak at a conference that was filled with academics from the Sikh faith. I was able to share our methodology, our approach, and get a little bit of their I guess I would say, insight onto the approach that we hope to employ. And on the right side, I have a photo of some of the other ways we've tried to engage in the community. So it's a photo of the Sikh place of worship in Birmingham in Smethwick. And essentially by going to these community centers, these places of worship, and creating connections, we hope to ensure that this study has the widest reach and reaches the individuals who most need to be captured in this work. So just wrapping it up, to situate this work, what does this mean and why is this important? So at a foundational level, we hope to gain an understanding, as mentioned throughout this presentation, gain an understanding of the unique experiences of South Asian women. And what will that do? Well, we hope to use these findings and at a very foundational level and inform possible interventions, to inform down the line and policy changes on all levels, and close the treatment gap that exists and allow for South Asian women to receive the care that they need if they are experiencing mental health challenges during the perinatal period. Overall, this will amplify the voices of minority women in health research and hopefully contribute to better health outcomes during the perinatal period and beyond, not only for themselves, for their families, for their children as well, and overall work towards creating a just and equitable healthcare system. Now, before I wrap up, I'd just like to make some quick acknowledgements. I just want to thank my supervisor, Dr. Nicole Vichuba, who has been much more than a supervisor, who has kind of instilled the passion that she has for this PRAM project in me. So thank you, Dr. Vichuba. Also my second supervisor, Dr. Jennifer McLeland, who's not on this call, but who has been so helpful, as well as the Global Mental Health and Equity Group as a whole. Honestly, having peers that are also just as engaged in these topics is extremely helpful, just bouncing ideas off each other, and the support I've received from them has been instrumental in this project. And lastly, to South Asian Health Action, Kirat in specific, thank you for all the help that you've given us and for the opportunity to speak today, as well as our partners at Therapy. So thank you very much for listening. I hope that you now have a little bit a better insight onto the PRAM UK project, and I'd be happy to answer any questions.
Thank you, Krishna. Very excellent presentation and very simple as well, which is great for our viewers as well. And it's also timely because some of the work we've been trying to do is, we know that our South Asian women are not, and South Asian communities in general, do not get engaged in clinical trials or research because of the challenges you mentioned. So excellent presentation, and I'll share a bit later one of the pilot projects we're working on a similar nature, but it's great. Amrita ji, any quick pointers for Karishma in terms of her presentation?
Yeah. Thank you, Kirat. A wonderful presentation, Guru Karishma. This was like I think this is one of the very, very relevant topics and very important topics as well, because mental health, why I want to stress on this is there is one kind of a mental health which is acquired if you talk about gender in particular, which comes due to other circumstances and the child thinking something or a person in a particular situation. But in women, it is very much related with hormones and the cycle and with the gestational periods, with this postpartum period as well as. So the role of hormones and in connection of depression is one of the very important keys, I think, which we all need to make women aware about, where it is important for us to make them know that it is not your circumstances or it's not something wrong with you personally, but it's just because of the hormonal stuff and the cyclic stuff that is going on with a part of system of your life in which you need to empower yourself and know about your own self. And that is where the real sustainable solutions for the women to understand and feel themselves empowered. Now, this project of yours, I would say it's one of the very wonderful projects. I am also a researcher of PhD in mental health as well, and where we talk about all these things in awareness to the mental health with relation to the feministic thing and the disease or the leading cause of that and how you get addicted to certain other stuff. one very close connection of things is in this about the food habits, your lifestyle, the circumstances you have been living, what are the family pressures you have been in, and as you have rightly pointed on the cultural things, where every culture has a very diverse approach, understanding as well as the norms for a lady to be in a particular situation. But in that way, how to rise yourself up in a community and to make other women understand about the thing that is happening around, because it's something very common that will happen to most of the married women who will be pregnant. And most of us, even I wasn't much aware about when I had my babies, to think about, I'm really suffering from little depression, but why is it? And that kind of a depression is just a time period. But then you think, what's a permanent thing? What's happened? The whole life has stopped. Everything is finished. All the negativity, all the things that are giving you a pessimistic drawback to your life, they pull you in. So many things. But then you come to know, oh, this is pretty hormonal. This is very situational. This is transitory. And this will just go. When you think about all that things, I think we together can work so much on women to make them understand about their real situations, and also to make them understand how to live a better life, because their each individual decision just not only affects them but the whole family. It also, in one way or the other, affects the little child who is born within her, who is in the part of her life, and that in turn is giving a big relevance of understanding the approach of giving birth, the children, how their thinking are, why we think that many mental health disorders are very prominent in the children, the kind of ADHDs or other kind of diseases which are prevalent in today's time with the newborns and the toddlers, and then the children of today, has also some of the roles in connection with all that stuff. And coming from the field of holistic healing and Ayurveda, there's a very big reference of uh, Garbhopanay and Sanskar, where the mental health of the women is given a priority. And I really wonder that these people, so many years ago, also realized the importance of how important is the sanskaras in your lifestyle at that time, because it will be helping you in building up that mental resilience, mental strength, to understand yourself much more better and to give a better progeny. So when you talk about a progeny, we just stress, eat this thing during pregnancy, do this thing just to have a healthy child. But is it just a complete healthy child in that way? I think that's pretty incomplete. We need to build much more. And in the ancient time, look at our grannies and their grannies who had been in all that stuff, and so many children used to be born. There were so many brother sisters, and their mental health, their mental resilience were much more, and therefore our grandmothers, our parents are much more stronger mentally, that support us in tough times compared to what we look into the future. And that's what I have to say. Kirit,
Thank you. Thank
it's
you.
a wonderful work. I would definitely like to connect with you, and it's time for us to welcome Nicole. Over to you, Kirit. Thank you.
Yeah, welcome. So again, thanks to Nicole, who I met with Guru Krishna as well recently, in terms of looking at the work they're trying to do, and it's it's timely because of Guru Krishna is looking from the UK context to try and increase, through her research, increase the participation of the group she mentioned. And we're now going to go to India, although Nicole's in Oxford. So Nicole, let me just give you a quick overview as a bit of your background. So you're a senior research fellow at the University of Oxford, Nuffield Department of Women, Reproduction, Health, and a group lead for Global Mental Health and Equity Group. So, and you've been working on the Prime Project in India, and I was really excited when I first met you and heard about this exciting work you're doing, and wanted to kind of get the experience and the expertise and also the learning from what you've been doing. And so really over to you, and thank you for a global namaste to you, and also looking forward to your presentation.
Thank you so much, Kirit. Thank you very much, Amrita, for the wonderful hosting of this this show and for inviting us to be here. It's so nice to connect with people and to be able to share a bit of the work that we are doing. Yeah, and also to say congratulations to Guru Karishma, who has who's leading this work that she just presented and that she's doing so well. And it's so good to connect with these communities in the UK. So if you could allow me, please, to share my slides, then I will put them on. It says, I think it needs to be technically.
If you want to co-host, you can share your screen. Over to you. Thank you.
Thank you. So hopefully it will work.
Yes, we can see it.
Okay, do you see the full screen or?
No, we just see, you can put it on a slide mode.
Yeah, it is on the slide mode. So
Okay. We can see
sure
your notes. We can
just
see your
maybe I'll
notes.
say one second. I'll just, yeah, I don't need the notes, but is it okay now?
You can go and put it on your full screen and slide. Yes, perfect.
Perfect.
Okay, great. Wonderful. Yeah, so thank you very much. And I'm very pleased that we can present here. And so I will be giving a little bit of background to the work that you just saw from Gukarishma on what we're doing in the UK. And this work essentially goes back a few years now on research that we've been doing in India, looking at improving perinatal mental health in rural Indian communities and sort of the origins of the PRAM, the perinatal mental health intervention. So, I mean, Gukarishma has already done a great job in introducing the background, but one of the main questions and the point is really for me to maybe point out why women's mental health is important. And so we know that 1 in 4 people in the course of their life has a mental illness. And this means that at any given point of time, we see that roughly 20% of the world's population is currently experiencing a mental health problem. But unfortunately, 2/3 of people experiencing mental illness are not receiving treatment. And when we look at low and middle income countries, the situation is even worse. In low income countries, less than 10% of people are treated for severe mental illness. And this means also that we have a very high mortality rate. So 8 million deaths a year can be attributed to mental illness. We know that women who experience a mental illness die 15 years earlier than women who don't have a mental illness. And men even die 20 years earlier if they have a mental illness compared to men who don't have a mental illness. And these numbers come from high-income countries. So with all the compounding factors that we see in low and middle-income countries, you can imagine the situation is even worse. We also know that suicide is one of the leading causes of death in a number of people, and it's often related to mental illness. So suicide is a leading cause of death in children aged 10 to 14 years old. It's a leading cause of death for young men, and it's the leading cause of death for women of childbearing age in South Asia. And we see when we look at the Sustainable Development Goals, which have come out in 2015 and are trying to address a wide range of inequities and development issues, we see that mental health cross-cuts most of them. So not just in the SDGs 3, but really education, poverty, economic growth, all these issues are related and interconnected to mental health and to women's empowerment or women's agency. So when we go to the phase of pregnancy and childbirth, we see that it's a very critical period. So Amrita has pointed it out, Gukarishma has said more about this. It is the case that 1 in 4 perinatal women, so during pregnancy and after birth, experience mental health problems. And 15% of maternal deaths are actually suicides. As said earlier, suicide is the leading cause of death for women of childbearing age in South Asia. And for women, mental health is different than men's mental health. Women have specific mental health needs. And we know that problems that arise in regards to mental illness during pregnancy and after birth, they increase the risk for more severe and lasting, so chronic conditions. And women's mental health, of course, not only affects the woman negatively, it affects directly the baby, it affects her family, it affects the husband, it affects the communities. So it really affects the entire system. And we know that there's a number of risk factors for women's mental health. So we have adolescence, so early pregnancies, difficult birth experiences, having your children or living in poverty, gender discrimination, nutrition, gender-based violence, but also, like Krishma has pointed out, stigma, beliefs around that, low education, all these issues influence women's mental health negatively. And these can be grouped largely under what we call social determinants of health or social determinants of perinatal mental health. Social status, education, gender, poverty, all these things. And then things like sexual violence, domestic violence are often leading or very closely interconnected with bad mental health. But also issues like the dowry system, which is something that exists in India and in other cultures still, and that determines a woman's value, that has a close connection, or the social support network that people have around them, women have around them, influences mental health. And so my background is in global mental health, and I come with a very strong belief that it's important that people have access anywhere in their communities to mental health services, and these community-based mental health services. And we see in India, we have community health workers called ashas, that are very close to the communities. They know that there are people. And so how can we bring mental health together with the community and with the community health system that we have? And this is where the PRAM study, the perinatal mental health study, really started off. So our aim was, so we started off here, you see a paper, the protocol of the PRAM first study that we've, the PRAM 1 study that we've published. And this is in collaboration with colleagues from the George Institute, India. They're based in Hyderabad, in Telangana, and in Delhi, and colleagues from the TGI, the George Institute in London, UK. And so we've started off with this study in a setting which is rural India. It's a low-income setting. So I understand many of you have connections to India or are even calling in from India or maybe have family there. So it's 2 sites. One is in Faridabad in Haryana, and one is in Siddipet, that's in Telangana. And you see here in India roughly, so one is more south, one is more north. We know, we don't have a lot of data from it, but we know that roughly 14 to 30% of women in the perinatal phase experience anxiety, depression, stress, or suicidal ideation. And this is what we call common perinatal mental disorders, as opposed to severe mental disorders, which is yet another more severe issue. But we know that most women with, so these common perinatal mental disorders, as the name says, are very common. But most women who experience them do not receive care in this setting. And we have very little research on how to best address these common mental health problems in low-resource rural settings. So we started off with our study aims, first of all, to understand the mental health needs of perinatal women living in rural India, and to develop a theory of change. So essentially to develop a way how we can address this, but really working with the communities, understanding what is it they need. So very similar to the study that Gurkrishma has introduced earlier. What do people actually need? What do they understand? What is their view of mental health and mental illness, and how do they need support? Who needs to support them? What do they need? What do they need to change? Or what is working for them? And then how can we fit an intervention into what they need? And then to develop a complex intervention to support women with their perinatal mental health in the communities and understand, is it acceptable? Is it feasible? Does this work? And then to go on and develop to develop this intervention, but on a larger scale with many women, to evaluate, is this actually effective? So can we replicate this, and could this be something that could be recommended as an intervention more globally, or at least in the setting of India? So here you see ashas from Telangana. Ashas are the community health workers, and this is from a study called Smart Health Pregnancy, which is also done by the George Institute. And here you see a sort of a screening mechanism. So the idea was that ASHAs would screen women for their mental health, and then the record is being taken up. And so we tested it, and we did this sort of a preliminary understanding of what do the women need, what do the healthcare workers need, what does the community need. And this is what we did in phase one, which included a scoping review, which is a literature review, a situational analysis, and then these workshops with people to understand how can we bring change. And what we found from the data collection was that the first point when we asked women, what is your main concern as a woman or as the healthcare workers or the families, what is the women's most heavy mental health connected concern? And what we heard from people is that the main leading cause is the boy-child preference. So there is, even though in India, officially the sex determination is not allowed, but there's still a lot of concern around, is the first child should be a boy. And if the first child was a girl, then the second child at least should be a boy. So there's a lot of pressure on the women. And so, for instance, here we have one quote from the healthcare workers who said, if she delivers a baby girl, they will not care about her. If she delivers a baby boy, they will celebrate her. And the pictures you see in the background, these are pictures from women. They've consented to our research and to these pictures, and they came in to give their voices. They're partly women who experience mental health problems. They're partly family members, partly ASHAs. The second most stated reason for distress that women experience during pregnancy and after birth is related to relationships with the husband and the in-laws. And mainly that also includes domestic violence. So many women have reported problems in the family. The women in rural India usually move from their mother's maternal village and maternal family to live with the husband and the husband's family and in-laws. And so one woman, for instance, here said she was talking about the distress that she has living with an abusive husband. And she says, we think it would have been better if we were unmarried rather than suffering like this. And so it's socially for women in rural India, it's very important to be married and to have a husband. So you can imagine how heavy this sentence weighs reading this. And there's a lot of stigma. So that was another big reason for why women experienced distress during pregnancy and after birth. And so when we asked them, what are the changes you need for, during these periods? One woman said, they must not speak evil about us. So stigma is often even more pervasive than just, having people talk negatively. But it shows that in addition to the mental distress and the depression and the anxiety or whatever is weighing on the woman, there's also this fear of being stigmatized and being excluded from the community. And then there's poverty and livelihoods and nutrition. We've grouped it together because it comes sort of together in terms of how people can provide for women can provide for themselves or their families. And here we had a situation where we asked one of the healthcare workers, and she was telling us about a woman who had experienced mental health problems. We asked, so did she do anything? Did she seek help? And the ASHA told us she could not say anything in regards to getting mental health support. Neither could she care. She had small kids. They did not even have food to eat. So the reasons why mental health distress or mental illness may be there is very closely linked to these social determinants. And so what we realize is it's really hard to develop an intervention that just focuses on mental health if what the reason and the causes are external to mental illness, really. They're a social issue. And then we also had a lack of professional mental health support services in the villages. So when we asked, where do people with mental or women with mental illness get help? The healthcare worker says they don't get help. They have the families. If they're lucky, they have a good mother-in-law, they have a good husband. Maybe they have a nice neighbor, or the ASHA might look out for them, but there is no professional support system in place. And this is where the PRAM project came in. So we put together these points. So we have the point that women do not share their mental health problems and seek help. Most women do not receive professional support. And then we have very limited mental health services available locally. They're only in larger districts and cities. But it's very difficult to access these services because they're far away, they're expensive to get there. You need to take the bus. It's impossible for a woman and it might also be unsafe to go on a bus and travel there. They have childcare commitments or they need to cook. And this is all reinforced with social determinants. And this is where we started off, and we sort of took those learnings from the PRAM 1 study phase, and we developed the PRAM intervention. And so there's 4 components to the PRAM intervention. One is that the ASHAs screen the women and engage with the families to encourage the families to help the women and to essentially destigmatize, but also raise awareness for perinatal mental health. The ASHA screen the women for mental health problems, and those women then who agree will be invited to attend women's peer groups. So they're women's support groups where we talk about mental health, we talk about family issues, we talk about, the child, connecting to the baby, connecting to the unborn baby, maybe how to, care about your mental health in that state and support each other. And then, because we found out that social determinants is such an important part, we have included a component on social determinants that specifically identifies with partners how can we address those social determinants and work together with other experts in areas and locally who have been working on social issues for a long time. And then an anti-stigma community campaign in order to reinforce and to really strengthen and raise awareness for mental illness for women and for families to support them in the communities. And all that is done in co-production with people with lived experience. So the women, the community, key stakeholders like the district health officials, the primary care doctors, the ASHAs, the communities, the Gram Panchayat. And so this is how we started off at PRAM 2. And I'll just show you very briefly because, to show you a little bit what we've done. So we have started last year in August to roll this out. We trained our field supervisors. We had in both sites, so Haryana and Telangana, we had 3 field supervisors. They were female, they were trained, and then they screened the women. And they went out, and here you can see the number so we had a bit more than 200 women screened. And we had quite high numbers of women that were at risk. So we screened with 2 screening tools. One is for depression and one is more for anxiety to understand the risk of mental health problems for these women. And then we had women who were at high risk. So they had more severe symptoms that they would share. And then even we had quite a high number of women with suicidal risks. And then these women would be referred to the peer groups. And so the peer groups were called Healthy Mothers groups. And there were 10 sessions. We had 9 group sessions every 1 to 2 weeks. And we completed these in April. So we have just completed them. We don't have the evaluation yet, but generally we had very good feedback. So we had an initial session with the families and then these 9 sessions with the women. And here you can see a picture of our Asha on the right in the white. And she's talking to the women and she's after the training, and they're discussing things. They were sort of, here you see our PRAM guide. So the woman is showing, and the Asha is showing the women some things about, essentially it's a lot to do also with CBT, so cognitive behavioral techniques. So reframing your thoughts when you're recognizing when there's negative thoughts happening. And sort of how can you catch yourself and change and try to, take time, also breathing techniques. And then here you see some more physical activities where the women were encouraged to, feel the stress and then release the stress, active muscle relaxation techniques. And then we also had some other exercises were physical, where we were singing and the women were doing some clapping exercises. And I don't know if you can see, but there are some women are smiling, and generally we heard good things about it, and the kids were there as well. So it was possible to bring them together and to support each other. And so we're currently evaluating, maybe just to say that, we're evaluating from these groups that we had in North and South, and we're evaluating the feedback. Generally, we heard really good things, and the women found it supportive. Some women said that they found a friend. They didn't have a friend so far in the village, but now they found a friend through the groups. Or one of the women said she was very happy because she could learn how to reframe her thoughts and sort of start thinking differently. Some of the women even started telling their in-laws, look, I need some time to myself. I need some time for my mental health, which is in a way a very good thing, but also, of course, requires engagement with the families so that they can understand that need. And then we have the social determinant part. And so what we did here is we brought together groups of, so here you see pictures. These are different groups from Telangana, from Siddipet district. And they have been working on issues such as tribal health or tribal groups. And then you have even some that work for women's gender equity groups, or some groups that worked on domestic violence. We had some poverty reduction groups. So these are charities or NGOs that have been working, so grassroots organizations in the field that have been working on these issues for a very long time and have been very, very active, and they know exactly what is happening in their district. So we have sat together with them, had a discussion. So where do you see the issues of perinatal mental health in your communities and in your work? And how can we bring it together, to work and to strengthen both maybe the equity issue or the poverty issues or the tribal other issues, beliefs or something? And how can we work together on this? And so we developed in Telangana with these groups, and we did the same in Haryana, in Faridabad, and you see my colleagues there on the right, Sandhya and Nashad, and then we had on the bottom you see a professor from AIMS, and Professor Palab Maulik was there as well. So it was very good, the support and the connection we made with the communities. And now we are hosting a national level. So we're bringing together the findings from this, and we're hosting a national consultation on developing interventions for perinatal mental health and social determinants. And the plan is in the second week of September or third week of September in New Delhi. And so please reach out if you have any contacts, or if you would like to suggest someone or are interested. It will be a high-level consultation. Yeah, it will be really good to bring together partners working globally or in sort of nationally in India, but also experts like UNICEF or WHO or someone we're trying to bring together to develop a way to address perinatal mental health and social determinants.
Nicole, thank you very much.
Thank you. Sorry. Yeah, I'm just
go on. If you got
coming to the end, I'm almost there.
Okay.
Is it okay?
Go for it.
Yeah, it's just that we have the community campaign. We're developing this based on stigma programs that I've worked together with. And we will then evaluate the intervention, and that's what's currently happening, and then scale it up for a greater impact. And so the aim of the PRAM project is to support happy and healthy mothers and happy and healthy babies within supportive communities. And thank you to my team in India, all the colleagues, and then also thank you to the Global Mental Health and Equity Group here in Oxford and colleagues. Yeah, and please do contact me. Thank you very much.
Thank you. Okay, thanks again. Go on, Ms. Deji, go for it.
Yeah, it was a very, very wonderful presentation. I would say what Gur Karishma has added. Now I can see the whole ocean behind which the drop was released, actually. So that's very wonderful. I would like to congratulate you personally for initiating all this, which is such a big thing and a much required thing as well. And definitely we would like to plug in as this kind of conferences and annual meets that you organize in India and in UK, so that we can spread a greater word of mouth in different communities, not only in this part, but I think the African tribes also, where our resident contributor, our kitchen episode producer, Seema Bhatia, who through Art of Living has been working on a project Pavitra, which is about sanitation of women and in relation to their menstrual cycles and taking care of themselves. So I think over and above, Nicole, you have hit such a very sensitive thing, which I think is a very important need of an hour, which should be brought into the education system, as has been the sanitary pads being introduced in the schools now, where people are not afraid about it. And now the girls walk, that is my right, I must have it, I must utilize it, and I understand. And equally the understanding of the boys to know about and respect that thing as well. And same way, the need to understand a girl by itself in her own way, and especially this kind of things where you are getting married, you don't know what kind of socio-economic conditions are. Even if you know a little bit, still there are so many family pressures. Under those family special pressures, you also don't know how the family is, and in that, how resilient you become, how flexible you become, how adjustable you become in that sensitive time of caring and taking a decision to be a mom. And your data, which showed about the suicidal rate of the childbearing age women, is very right, because that's the primary age where a girl has to think about her career. She is getting married, she's forced to getting married, or she's in relationship, or the circumstances have changed. There are a lot of pressures on many ways, which I think a man doesn't have. And in that way, a woman to get education and to know about herself will help her in designing those parameters for herself. And the communities that you build in for taking up the villages at Gram Panchayat level with Asha, Anganwadi workers, I think is very, very beautiful. I must say, you must include other practitioners as well as the healthcare workers in different fields, which will give a big strength to the community work that you are doing. We have Dr. Batra, who is our homeopathic guru. We are linked with Ayurveda. We are linked with yoga healers. So these kind of holistic therapies will ingrain in public those kind of challenging times which as women at one time faces. And I think this will build up a big strength. What is your take, Kirit, on that, what has been added? And then we welcome Nandini ji. Over to you, Kirit. Thank you.
So excellent to see the work that you're doing in India. My kind of challenge to yourselves and to other, we've got a number of professors here today, which is great to have you on this platform. It's really about how do we really bring our own kind of culturally sensitive and culturally not therapies, but in terms of interventions, so we don't bring to India and other countries westernized concepts. We need to look at the westernized concept, but how do we make it true to our communities? And the only way that will happen is by the work that you're doing in terms of the community work, getting the peer, the lived experience women to kind of give you those ideas to say, okay, well, let's put CBT to one side. We want to call it something else, but this is what we want. We're going to amalgamate the Ayurvedic practice, we're going to meditation, we're going to look at, and then the kind of self-care is most important as well. So I think it's a challenge, but I think I've seen this in the UK where we've had to try and bring cultural competency, but that competency is not, it seems to be incompetency, because we're still providing the same old to people who need the services. But I don't want to get onto my soapbox, but that's really important. But the next speaker, we've got Anukul,
Dr. Anukul, we have,
yeah.
Kirit, you have pointed out at a very, very important aspect, because taking care of the norms of the socio-economic conditions as well as the solutions that will be cost effective to these people. We must not forget that the South Asian communities are among the poor communities as well, which cannot afford, and they are the ones who lack a lot of education in that way. And what best services can we provide on that level? Let's talk about it further on that, and we'll have a comment from Dr. Anukul also in a while. It's time to welcome Nandini from UK. Over to you, Kirit. Global Namaste.
Again, Global Namaste to Nandini ji, who's also a great colleague, and over the years since we've connected, has become part of our Saha family. So it's good to have you. Professor Nandini is also a consultant psychiatrist here in Leicester, in early psychosis. But today, the connection really is about the wonderful work she's been doing around the World Health Organization, MHGAP, which is something that's rooted in the community where there is no infrastructure around mental health services. I've done your introduction short, so please, you have a number of accolades. So I'm going to let you tell us more about the kind of accolades, and also you're also a professor. You're also involved in the psychiatry, family and associations. But welcome to Healing Our Earth, and you can see that kind of you're following nicely from Nicole, and really the work that you've been doing across Africa and also India from your own background as well. So thank you, and over to you.
Thank you so much, Kirit Bhai, and for that warm welcome. Nicole is a hard act to follow. I mean, that was touching so many buttons, Nicole, I must admit. So I'm going to talk about MHGAP. That's the central topic. But I'm also going to veer from that into my area of expertise, psychosis, linking with MHGAP. And most importantly, we are talking about the power and the healing power of communities over here. So that's going to be the flow of my talk. MHGAP I have talked about previously in these forums, but just for reminding ourselves today, MHGAP is Mental Health Gap Action Program. It's a WHO initiative which began almost a decade ago, and it is based on a manual, the MHGAP Intervention Guide, which is available on the public domain on the WHO website. And the principle behind MHGAP and the intervention guide was a manualized approach in the community to identify, signpost, and treat some very basic mental health conditions, to scale up resources where enough was not available. So if I simplify that a bit more, let's say we have areas anywhere in the world where there are not enough qualified psychiatrists, psychologists, psychiatric nurses. The mental health gap booklet was put out to, let us say, primary care workers, to religious healers, to people without a qualification in mental health, and in a very simple algorithmic way, helped these people in that primary care setting to identify the main categories of mental health problems, or what mental health gap called the MNS disorders, mental, neurological, and substance use, and then also gave a very clear algorithm as to how these disorders could be treated at a very basic level and how they could be followed up. And then there were stages in the algorithm which said that if things are not improving, this is where you send it over, this is where you refer, you involve a specialist. So instead of everybody in a place where there is a lot of need, everybody having to see the psychiatrist, or everybody seeing a psychologist or a psychiatric nurse, this was part of those issues being dealt with at the primary care level. This was the entire initiative behind it. And the MHGAP manual the intervention guide has been translated into various languages, and it has been used in various parts of the world. Now, the debate again comes on, and Kirit has touched upon it. And I think we should not be afraid to bring up these debates and challenge ourselves. Is this a Western concept? Is this again a Western concept being introduced in lower and middle income countries? And I can say, using the image gap, and Kirit has been through a number of sessions of those, in that the image gap is designed to be very culturally bland. So it has the very basic structure to it, but it is supposed to be administered and used by people who are used to the culture and setting, who can then add their cultural nuances to the different categories. So when people do image gap training for the trainers in another country, the perfect way to do it is to train the trainers. So let's say if I was going to help implement image gap in Uganda, which I was involved in a certain project, I did not go to the frontline workers, to the primary care workers, and train them in image gap. My involvement was with senior psychiatrists and psychologists in the system in Uganda. And then they could go and deliver the manual to their primary care workers and insert the cultural nuances into the questionnaire, into the algorithm. They would know what parts to take and what parts to slightly tweak and change for their cultural setting. That's the way image gap works. My experience in image gap, though, has been varied. The first time I used it was in a project in Nigeria that our organization, our NHS Trust, where I work, has had a long link with. And I did have that first-hand experience of teaching image gap in the front line, but it was with a setting that we had worked with for years. So we did have some cultural awareness. We did have those sensitivities working with the people we taught image gap to for a number of years. And where image gap helped us was that when we started helping the Nigeria project, when it came to teaching them about mental health awareness, we were doing a DIY thing. Whereas with image gap, you have a manual that has been worked on internationally, has its updates done by the WHO with involvement from various countries. In fact, there was one point where I went to do a training, and there was a lady in the group who was actually part of the focus group. She was part of the many hundreds of authors of image gap over there, which was a pleasant surprise in Nigeria. And then when I trained the Ugandan psychiatrists on image gap, I could share practices with them about the kind of obstructions, the kind of difficulties that can be faced in frontline training. If you're going to rural areas, there is stigma, there are superstitions, if people have different approaches towards mental health, especially if you're treating people with psychosis. Psychosis can be one of those very difficult to understand mental health conditions. And what image gap introduces, the idea of mental health issues not being this one overarching rubric. And that's where I'm going to shift a little bit into trying us as a group to think about not just mental health issues as one unitary concept, but just as we are thinking about cultural nuances, the world of mental health in itself has a number of nuances. I am always fond of saying that mental health is not a single chapter in the book on health. It is a textbook in itself. So just as you wouldn't go to a forum and, let us say, talk about all physical health conditions in one breath, you're not going to give people bullet points and suggestions about how to treat arthritis and kidney stones and migraines and cancer and color blindness and epilepsy in the same breath. So we cannot talk about depression and anxiety and schizophrenia and bipolar and substance use in the same breath. Each category has its own needs, its own research, its own prognosis. There can be a lot of overlap, just as you can have an overlap between diabetes and cardiovascular illness and diabetes causing secondary complications. Thereby, mental health conditions can influence each other, but it is to be aware of these various categories. And also to touch upon how I came to know about Kirit and Saha was I had the pleasure of talking about MHGAP to our mental health ambassadors, and later on went on to do the same work for another mental health charity for South Asian diaspora, the Sangeet Foundation, which is led by a wonderful couple who have lived experience of neurodiversity in one of their children. So again, talking about the awareness of mental health conditions, neurodiversity has come in the focus in a big way. I think across the world, we talk about it more, and it's important to think about our language and how we put forward neurodiversity. There is an increasing consciousness of not to put them as mental illnesses, to not to consider them as mental disorders, but to understand the diversity of the condition. And yes, when you are a neurodiverse person in a neurotypical world, when you have autistic spectrum conditions or ADHD, the acronym still has disorder in it. When you have those in the names, unfortunately, but coming back to when you have neurodiversity in a neurotypical world, and a world which is shaped for the neurotypical, it does become very, very difficult. It does become a challenge to navigate. And thereby, we as neurotypical people, if we do not have the lived experience of autism or ADHD, we tend to consider them as disorders because people have difficulties in their lives. But if we try and understand how the world looks to a neurodiverse person, not only do we break the stigma, but we also tap into the strengths, into the potential of people with neurodiversity, because all they have is a different way of looking at the world, a different way of looking at social situations. And it's about understanding that neurodiversity is not similar to an illness that people can develop. People can develop depression and anxiety. People can be anxious by nature. We all have our different personalities. And over and above that, people can develop serious mental illnesses like schizophrenia and bipolar. Now, is schizophrenia a Western concept? Is it something that the West has shaped and then told the world that, you all have to follow this concept? And I can speak from the heart there because I have a postgraduate qualification from India. My medical primary qualification is from India. I did my first MD in psychiatry from India before I trained in the UK. And I am very grateful to life to having given me the opportunities of having seen patients firsthand in Nigeria, in Malawi, in various settings across the world, across 3 continents, if I look at it that way. And I can absolutely affirm that psychosis exists throughout the world in a very, very similar way. So people with schizophrenia, whether they live in a city of the United Kingdom or whether they live in rural Nigeria or rural India, still experience auditory hallucinations. They all experience persecutory delusions. They can all show disorganized behavior. They can all become very different people to who they were before psychosis struck. And it can be very frightening because there are mental health conditions we understand intuitively as humans. We understand depression, we understand anxiety, because these are emotions we feel on a day-to-day average human life and part of experience. It is only when these conditions become too persistent and too severe that we categorize them as mental illnesses. But somebody starting to hear voices can be very frightened, very bewildered. And that is where our education within the community is lacking. Many of us can go through life without having a first-hand experience of psychosis. And thereby it can be not just frightening and bewildering for the patient, it is extremely frightening for the family. As a mother, I could possibly understand if my child came back from school crying and saying that I've failed today's test and I'm stressed about tomorrow's homework. That's understandable. But it's not understandable if I was a mother with absolutely no mental health awareness whose child came back and said, "You're poisoning my food and you've put cameras in the room because you're colluding with the government and you're in a conspiracy against me." That can come as a huge shock. And whilst we are talking about involving the community, involving families, we are talking about healing the earth today. I think the central point I want to put forward is in all the talk about mental health well-being and how we look after ourselves, let us not forget the illest people in the mental health world, within mental health services, who, in perhaps my biased opinion, are people with psychosis. And a society is known not by the way it treats its strongest, but how it treats its most vulnerable. And I think within mental health conditions, psychosis is one of the greatest vulnerabilities, one of the neediest groups that we are talking about. But there is hope. And I think the biggest analogy, the greatest analogy between physical health and mental health in that respect, I think, is between cancer and psychosis. So cancer is not just a single illness. There can be many types of cancer. And depending on when you catch the cancer, depending on what kind of prognosis, what kind of response to treatment it has, people can have very different outcomes. And it's similar in psychosis. People can have schizophrenia, people can have acute and transient psychosis, people can have drug-induced psychosis. It depends on the genetics, it depends on their past history of trauma, it depends on the family support they have, the community support they have, it depends on their pre-morbid level of functioning, and it depends on the understanding, the support that we can give them as a community. The support that their families can get from the community, because I come across families day in and day out in my job who say that they can't talk about what their loved ones are going through because people won't understand. They fail to share the very difficult circumstances they might be going through because they feel they will be judged as parents. Why is your child behaving so oddly with you? Have you done something to them? Is there something wrong within the relationship? Is there something wrong within the household? So there's a lot of education to be done around psychosis in the community. And that brings me back to the image gap work that I've done with Kirit and the rest of our wonderful colleagues in SAHA, because it was all about awareness, destigmatization, and helping people in the community linked to the right services if we come across people with certain conditions, to try and identify those conditions and not put everybody under the same umbrella. So I think that's all I have to say. Thank you very much, Kirit.
Thank you. Very, very always good to hear you. And as a professor, I was really enlightened that you didn't have any slides. So it's really great because you always speak from the heart, which is and passion, because obviously this work can't happen without heart and passion. So so again, Amrita ji, what do we have to say about Nandini ji and her excellent presentation and the work she's doing?
Yeah, thank you, Kirit ji. Lovely work, in fact, I would say. And the word itself is very fascinating, image gap. So, and especially I was just thinking, yes, the mental health, we always have certain image gaps that we create in our minds. And because of that, there's so many issues in our lives. And that um, is really very creditable. And I have my best wishes, whatever best we as a group can do and empower people on that verge, we will definitely be doing all that, which is really very remarkable. And yeah, over to you, Kiran.
It's quite timely if we can bring Professor
Dr.
Raghu.
Anukul.
Oh, and also we'll
Dr. Anukul.
Anukum,
Yes.
yeah, sorry. Global Namaste, Dr.
Global
Anukul.
Namaste.
Namaste. It was such a pleasure listening to these talks. I mean, it puts me back into my clinical condition. Let me put it like this: I'm a trained orthopedic consultant and basically a spinal surgeon. And as it happens to be over the life, I've only learned that I'm all the time interacting with human beings who have got a mind and a brain and a consciousness to work with. And most of my patients are the people who have got chronic illnesses, and they're running between the clinical psychologists, pain consultants, and others. And let me put it like this: had it not been for me being an orthopedic surgeon, I would have certainly been a psychiatrist, because we were two fellows in our class in our room, and myself and my colleague were both of them were grossly interested in psychiatry. I'm talking of my duos in the medical school. One of them did turn into a psychiatrist and became one of the senior advisors in the army. Unfortunately, died 2 years ago, which was a very sad thing for me. But I was certainly prepared for it for a long time, and I spent lots of time in the psychiatry ward. So it is next to my heart. But what is very much interesting is the way of we classify the things in our traditional Indian medicine, traditional medicine over here in the Western medicine, as we call it. And then we classify into psychosis and neurosis. I think psychosis is clearly in the domain, is very much into the hands of psychiatrists. But what I usually find is something slightly different, because after going through all the reading, I've been very much into Vedanta. And I think there is much more greater solution over there than what comes into this thing. So when it comes to women's concept, I've been very much going through lots of literature and studies by Sinu Joseph. I don't know how much anyone have read about Sinu Joseph and her literature on, particularly related to menstruation and Ritu Vidya, the concept of this thing, and also whatever of education. So when I was listening to Kirit's topic, the concept, it is not unnatural or not unusual for people to classify the entire South Asian group as a group. It's not a homogeneous group. It's a very heterogeneous group, extremely different in its concept. And it's a question of how much of autonomy is given to the women and what women know as their place in the community. Therefore, I do believe the religion and the Western and cultures have significant impact on the way the people behave. But also in the UK, I also find there's a huge conflict between the women's concept about themselves in relationship to what they have got in their own country vis-a-vis what they see over here. These are greater contradictions. They say, oh, in our country it is like this, but over here they don't believe it. And therefore, the daughters who are born in that particular house have completely different attitude than their mothers. And I come across that particular conflict very, very many times between the mothers and daughters. So it's something that I will learn much more from Professor Nandini. And I would certainly like to connect myself, because this is next to my heart, frankly speaking, because I very much deal with it on a regular basis. And I would sincerely want a greater differentiation between the type of community that we are handling within the, say, called minority South Asian group. There's a huge difference in the way, because I've seen patients who have been completely paralyzed from Afghanistan who are brought over here in this group. They're completely paralyzed, but in reality, neurologically, they're intact. They came with a whole lot of things in this thing, but in reality, this particular lady had seen her son being shot in front of her with the brain blown up in front. Then there have been other very many. I see many patients, but they've been brought in my neurology and neurosurgery clinic, and I find the causes are very different. But only if you spend time enough to realize what has gone wrong with them. Same thing when I go to India. When I saw this particular presentation by Nicole, again, I know I worked in many states in India. If I go to Mizoram, Nagaland, the attitude towards having child is very different from what you find in Punjab as opposed to Telangana or and other places. They're very different attitudes. But I find much more in the way what is another interesting thing that I would request is to tell me how does it feel to be seeing women who are in a place like Nigeria who are Islam dominant as opposed to Christian dominant, as opposed to what traditional this things. I would be very keen to know something like that.
Okay. Thank you very much for your reflections and insights. And Kirit and I are based in Leicester. And one of the jokes we have is that you can eat your way through the world in Leicester. That's the not, and it shows the diversity of the community that we work in. So cultural competence is not a luxury if you work in Leicester. It's an absolute necessity. Necessity. You cannot do without it. And you've raised a very good point of that, all communities are, different. Yes, when we are thinking about various nuances that we shouldn't consider depression and schizophrenia the same. Oh, but we consider the group South Asians the same. No, wait a minute. There's a difference even there. If I go very deep into it, when we worked in Calcutta, we found differences between North Calcutta and South Calcutta, and there can be a wide variation in the experiences of women. If we're talking just about women, let's talk about, back home in Bengal, the experiences of, women living in cities and women living in villages could be very variable. And this absolutely shapes what we see of ourselves as people and identities. Now, when it comes to psychosis, we have an easier job. And the reason being that psychosis being the more kind of neurologically driven group of disorders will present similarly across the world. And there are very interesting studies that we sometimes forget. There is international pilot study of schizophrenia, which was done across 5 continents, 9 countries, and it showed that schizophrenia presented similarly. But when you come to something like depression, anxiety, when you come to the impact of bereavement, when you come to the impact of childbirth, how childbirth is conceptualized, what is the behavior you expect of a mother, that becomes very culturally nuanced. So actually, the support you give for mental health well-being, generally for prevention, is going to be a lot more localized than you do for serious illnesses. And let's say, for example, a particular kind of cancer, you'd probably treat similarly across the world. However, again, over there, taking into consideration genetic differences in response, which again, we are becoming quite aware when we treat psychosis. But you'd still look for the same kind of findings on images, etc. But if you're looking into, let's say, a nutritional status, then you can look into kind of differences that you can find across the world depending on, the problems, but specific problems over there. About dealing with women coming from different backgrounds, it's just been a fascinating journey, which I think if I started to talk about, we could talk till late evening. And all I would say is that as professionals, as human beings, as compassionate citizens, we just need to go into all these settings with a very open mind. There's no end to learning, about different cultural practices, and be aware of the stereotypes that we hold in our mind. I'm aware that when I came to the West, when I came from India to the UK, I had stereotypes in my head about people who have been native to this country, and it's taken time to break those stereotypes. And about being open with each other, about having that cultural exchange, being able to have honest conversations about being, oh, sorry, I thought this way. Maybe you can educate me, maybe you can tell me. And the world, when we are healing, needs those open conversations. So I think that's trying to put a lot of complexity into a single sentence. But it's kind of the fact of the more we know, we realize how little we do.
Thank you. That's been a great
Thank you very much. Yes.
conversation. Yeah, and I think what we're going to do is it's fortunate and we're privileged to have, you know, Professor Raghu joined us. He's also somebody who we've worked, and he's also from Leicester. So we're having some amazing professors from Leicester who are, you know, doing some fantastic work around community and community engagement, and also they talk not just as academics. I will say that I can vouch for both of these. They actually, you know, work from the community, and they're rooted in the community as well. So without further ado, I'm going to just introduce Professor Raghu, he's a professor of mental health at De Montfort University in Leicester. His work encompasses global mental health and public mental health perspectives, resilience and well-being, culturally appropriate mental health literacy. So today, his presentation is going to be around health literacy and community mobilization. And again, really great to have you there. Global namaste to Professor Raghu for joining us. And, you know, while we've got Nandini ji as well, just a quick reflection on, you know, the presentation, and obviously what can we be doing more of in terms of connecting what Nicole presented, what Gurkrishma is doing in terms of research. How do we really, you know, we need to break the kind of barriers around getting some of our communities engaged in research and co-researchers with that lived experience, because we're still seeing a really lack of, you know, institutions engaging with those with people with lived experience or people from the community. So I'd like to just focus on that in terms of how do we go about doing some, you know, co-designing, co-engagement, co-research from people who live the experience as well. Go on, Raghu. Go on,
Yeah.
go for it.
Okay.
Yeah.
I think there can be focused research. It depends on the topic. If we can do research on particular communities to make sure they are included. But at the same time, if we are doing multicentric research in the UK, I can't see a way of, you know, how we can leave out certain denominations. And perhaps I'm a bit blinded by my own experience in Leicester, where my caseload of, you know, we in our team we have a caseload of around 500 people with first episode psychosis across Leicester, Leicestershire, and Rutland. And we'll probably have to go back and count how many countries and communities they come from. But, you know, on the top of my head, there's hardly a continent left over there that I haven't had a patient from.
Sure.
There are certain, continents where I can have more, and, you know, my patient load is hardly dominated by just white Caucasian. You know, I have a mix throughout. So if we were doing a service evaluation on my caseload, generally throughout, we would automatically include all these communities, people with diverse experiences, people who have lived here, born here, but come from diaspora groups, people who have come here as a matter of choice, economic migrants, or people who have come here through a lot more of tragic experiences. There is a lot of work done across about inclusion within the trust, within the training that we do with our professionals. And the research then, you know, depends on, you know, looking at whether our caseload is reflective of the population statistics we have within Leicester, Leicestershire, and Rutland. It's keeping an eye on those numbers, I think.
Amazing. Okay, Professor Raghu, thank you for joining us. I'm going to let you give you your slot to kind of present the wonderful work you're doing, not just in.
Thank you, Kirit. Thank you, Kirit, and hello, Nandini, and hello, all respected panelists here. So, yes, I think I agree with you, Nandini, on the cultural narratives, and I fully agree with you on that perspective. And I think what we actually have an issue here is not in relation to the kind of cultural nuances that are not actually included in it. But I think the service, especially in the UK context, I think the services are not being very responsive towards that cultural sensitivity of things. The cultural interventions are not actually there. And I think it is not as if we have discovered this culture in the last 24 hours. We have abundance of evidence for the last 60, 70 years in relation to racism and how racism plays a major role in relation to access to services and also access to interventions and all those things. And I'm not speaking to a converted psychiatry group like yours, but I think there is that issue. As to how we actually do that is something that obviously takes a lot more conversations and a lot more work in relation to. It is not a criticism, but it is just a point that I wish to raise. Really.
Thank you. That's great. So
okay,
let's
just
have
share
your presentation. Yeah. Yep.
Yeah. Okay.
Thank you. Again, thank you, Nalini ji, and we'll definitely, if you have time, just please do stay. But we know you'll have only one day off, so we let you enjoy your day off as well. So thank you for joining us.
Thank you.
Right. Can you see the slides?
Yes.
Okie doke. Right, so I'm going to move away from Leicester and I'm going to talk about a project that we did in the southernmost state of India, a place called Kerala. The reason why we wanted to go to Kerala was because of the health conditions and the health services in Kerala are actually in par with the most of the Western world in terms of human health index and other things. So this is actually a project funded from the UK Research Council in relation to promoting mental health literacies through community mobilization. So what do we know?
Do you want to put your do you want to put your presentation in slide mode?
In the
Thank you. Yeah, perfect. Thank you very much. Yeah.
So what we have here is actually from the Western psychiatry perspective, there is the kind of mental health literacy, as they call it, is the kind of ability to recognize specific disorders or different types of psychological distress, and also knowledge about risk factors and causes, and knowledge about self-help interventions, and knowledge about professional help available, and attitudes which facilitate recognition, and knowledge about how to seek mental health information. So the National Mental Health Survey of India actually talks about that mental health literacy is a kind of a need of the hour. And I think there should be more understanding about how to promote mental health and well-being, and also early recognition, care support, rights for the people with mental ill health, and also destigmatization. All this is wonderful statement, but how do we actually do that from the community perspective without the actual transplantation of the Western psychiatric models to the Indian context? So I think there are a number of programs in relation to mental health first aid or mental health literacy, as they call it. So what we wanted to actually do was to look at a feasibility study as to how best to actually promote that socially and culturally appropriate mental health literacy is using participatory approaches. And I think people talk about co-production, co-creation of knowledge, but I think it is still a unitary kind of concept. And we really need to actually engage with communities. We really enable and empower communities to actually share that knowledge as to what the communities actually think and what is their perspective. And I think those kind of approaches are still clearly lacking from the mental health perspective, or wherever that is actually present is conveniently ignored, that is not actually taken into kind of service models. So this is actually study in relation to that. So in the Kerala context, what we have is about 13.7% of the national prevalence of mental health disorders. It is worse in urban and rural lower income areas. This is from the National Survey of India, Mental Health Survey of India 2017. So the Kerala has got a number of successes here in terms of a population about 36 million people, and human health index of very high in any compared to any other state in India, and to the highest literacy rate. And I don't know what literacy actually means. If you actually look at purely from the perspective of reading and writing, yes, that's right. And also the kind of health literacy as well is pretty high. Life expectancy is pretty high in Kerala, and one of the lowest fertility rates in Kerala. And healthcare and primary healthcare and tertiary and social healthcare is actually quite highly pronounced. So Kerala represents the kind of direction maybe in relation to how other regions of India may decide to travel. But the Kerala model has got a number of challenges too. About 14% of the adult population of Kerala experience mental ill health, and this is actually recorded in the Keralan statistics. And I think the suicide rates in Kerala is double the national average of India, which is about 12 a number, but 6% from the 6 point something percent in the Indian context, and about 12.5% in the Kerala context. So, and I think depression, many people talk about depression, many people talk about anxiety, and I think the fast socioeconomic transformations are a major factor in relation to some of these things in the Kerala context. And the decline of the joint family system and high standards of education and low employment, and the labor migration to the Gulf countries and also now more towards Western countries as well, and high expectations versus harsh economic realities. Alcohol consumption in Kerala, alcohol consumption is famous in relation to one of the states that have higher alcohol consumption in India, and the school pressure on children in terms of higher performance and higher outputs is also a major concern. So with that in mind, and I think this is actually an international team. There's a number of people from the UK, from Loughborough, from UCL, from Middlesex, and also we actually worked with the NIMHANS and the Tata Institute of Social Sciences, and also a couple of organizations, NGOs based in Kerala, the Mental Health Action Trust, and also the Mahek Foundation, and also 2 theatre companies. We used applied theatre, storytelling, films, and as a major methodology to actually mobilize the communities. So we had a theatre company that actually worked from the UK, and also we had a theatre company that based in Kerala. So how did we want to do that? This is the kind of, I'm not going into the kind of academic jargon, but I think it's more to understand what we actually did. So how is the mental health literacy is actually shaped by economic, social, and cultural context in Kerala? So, and what about the kind of rural and urban context? And how do they actually culturally, how do they construct a culturally and socially appropriate meaning for mental health literacies? And again, we wanted to know how was the best way of actually engaging with urban and rural communities in Kerala to discuss mental ill health. Because regardless of the high literacy rates, there's the heavy stigma in relation to having conversations around mental health and mental ill health in the Kerala context. So that's why I recently I'll ask a big question: is literacy alone is actually a major factor in eradicating stigma? As such, we think that is not the case. So how might we actually use a participatory action research model as an intervention for mental health literacies? And how can we best engage with the communities and professionals and services for policymaking is the kind of things that we looked at. So I'm sort of cutting short the story about the full thing. This is about 4-year program that was completed in 2022. So I'm just trying to sort of look at the ways in which some of the key points from our study. So we collected as it stands. This is one of the largest studies from the global south, where we have data sets for well over 1,000 participants, both through direct interviews and also through theater making process and also through theater replays, etc. So, and we used, this is an example of an applied theater model here.
We've gone quiet,
So,
Professor Raghu. Are you looking for
Sorry?
something?
Have you lost me?
no, you're trying to put your slides back on slide
Okay,
mode. Yeah.
back in a minute.
Maybe you can stop screen share, find the slide and bring it back so we can chit chat. It's okay.
Okay, sorry. Right, so moving on from here, I think it's because I just wanted to
It's come back to the music. Is it music there?
You've got your video playing again. Yeah, that's it. Okay.
So this is another way whereby we actually interacted with the tribal communities in relation to music and dance, so that we can actually try and enable people to talk about it. Okay, so from the kind of explanations of mental ill health, most people actually talked about the kind of biological context, the hereditary brain abnormalities, old age and pregnancy, and all those things were actually stated. And also the kind of psychological context in terms of death of a significant other or spousal abuse and abandonment and tension is actually a word people quite often mention, as opposed to stress. And also, there is the economic burden of overreaching the theme of rural states, really, in rural sites, and also the social context, social pressure, work issues, family atmosphere, and the Gulf migration are also major social factors here. And also the cultural context in terms of how ghosts and jinn possession and God's curse and black magic and all those things actually work. This is the kind of broader concept that people stated, both from the interviews and also in terms of the reaction, how we mobilize the community to talk more about what are the issues and how do they actually create that mental well-being and resilience. So the social cultural strategies for well-being from here is actually kind of the prayer is something that people generally mentioned, and visiting religious institutions is a key factor here. Altruism and recreation, self-help, and astrology is actually a key factor here, because most people actually saw an astrologer, and also a psychiatrist and a psychologist and a faith healer. And also spoke to the kind of community groups as well. So you see a multiplicity of actually help-seeking models from this particular study. So we also developed something called the Mental Health Literacies Questionnaire, MHLQ, which is an adapted version from young people mental health literacies standardized within Portugal. And so we used that within the Indian context, which they widely understand our post-theater, post-engagement context about what people think about mental health and mental ill health. So from that, I think it is not rocket science, but I think it's in relation to the concept. Broadly, what people actually talked about, is what are mental health literacies? Because I think the Western way of actually looking at mental health, it's actually a mental health literacy. It's a singular concept, but we think it's actually a plural concept because there are literacies that people actually tend to do in relation to promoting that mental health and well-being. So, what is mental health? Because I think what is absent from the Western psychiatric models of mental health literacy is about what is mental health and well-being. They automatically go into what is mental ill health. And I think we need to talk about what is mental health and how do people construct that mental health and well-being in the first instance. And then we want to look at the mental ill health. And also there is the mental distress that is not actually disorder in itself, but I think those people actually might experience some of that. And I think how people actually try and find help-seeking models as a result of it. And what are the causes and triggers of mental distress and health disorders, and how can self-help approaches actually promote mental health well-being and resilience, and how can we best encourage help-seeking professional and lay support for mental health issues, and how can we best confront and address the mental health stigma among young people, and how does cultural heritage practices enable to empower us and create mental health and well-being and resilience. So it is the feminist dimension that we have actually added here as a result of this particular study. So, and I think one of the major factors that people have actually said is about faith and spirituality. And I think they said faith and spirituality actually provides meaning and a purpose and actually creating that well-being in many dimensions. They might all see a psychiatrist, they must all see a psychologist, but I think it is the kind of that extra layer of comfort, extra layer of reassurance that people were actually seeking. So mental ill health can be perceived in various ways in relation to both religion and culture. We already know that, but I think it's taking into account and bringing that into the kind of intervention models and assessment models is a key. Culture have a huge influence on both the perceptions and the experience of mental illness as of patients and others. And the attribution of supernatural factors, yes, I think it might not be all superstition. I think there could be other ways in which people might be making meaning out of it. I think relying on the will of God there are different ways in which people might be finding reassurance here through prayer, traditional healing methods, and the issue of faith and coping are more complex. It is often a collective process involving relatives and carers, as well as local wise men and women. So, from a policy and a practice perspective, what we want to question is whether mental health literacy is a way forward here. Because what we think that one of the best ways to actually achieve this is to facilitate a dialogue between medical, psychotherapeutic, and spiritual approaches. I know some of those things are already happening, both especially within the Leicester context and also within the Indian context. It's been happening for a number of years. But I think it's how do we actually bring that knowledge to the forefront is that kind of question. And we argue that for an understanding between medical, spiritual, and traditional ways of thinking about unhappiness and disorientation to enable the best from all these approaches to be incorporated. Because that is where we kind of have a kind of dichotomy here, the kind of a gap in relation to the Western psychiatric models and how that is not actually being looked upon from the broader holistic perspective that is culturally sensitive. So in the rush to actually modernize our mental health services, we would urge the policymakers and health leaders not to forget the resources, i.e. the human resources that people have, what people are actually using. And I think the coping mechanisms that one has, the resilience model one is actually adopting, and the ways of actually making meaning that already exist in many communities. And I think that is often forgotten. That is what we want to actually trying to bring to the forefront in actually making meaning and a purpose in creating what is actually a mental health. And because mental health is not mental ill health. Mental ill health is a different dimension. So how people make meaning out of mental health and how do they actually seek help for mental distress and mental ill health is a whole lot more than mere superstition and stigma is what we believe. And also, the kind of mental health literacy campaigns often assume that medical psychotherapeutic model of human distress or disorientation is superior than other forms of understanding. Mere superstition, stigma, they are all mistaken, really. By contrast, our own work in this particular work, and also in other work that we have actually done in India on resilience and other things, has suggested that traditional and spiritual beliefs give meaning and structure to the experience of mental ill health, provide structure to the day and a variety of activities which are meaningful to build social bonds with others. What some see as stigma may be a way of actually managing privacy and dignity. It is something that needs to be thought through. So some of the concluding thoughts here, literacy versus mental health literacies is something that we need to try and look at and eradicating the mental health stigma through that process. And I think applied participatory ways of actually engaging with communities is something that has been especially helpful in this particular example where people have thought through the theater pieces, through the film and storytelling. There has been an immediate impact in relation to people seeking help and understanding more about what is actually going on. And actually, respect, kindness, and compassion are key factors in relation to understanding those communities. Self-care and listening to yourself and reflection, and encouraging that fearful conversations around fearful mental health conversations, as we call it, can only happen through community mobilization. And mental health services in the Western way of actually looking at it, it is very much a deficit-based model. It is not actually looking at a strength-based model of individual. So I think it's about time that psychiatry actually moved towards a strength-based model of providing services, and where we actually accept culture and cultural heritage and attitudes, feelings and behavior in mental health. And also some of the creative approaches that people tend to actually use do provide those responses, those do provide that creation to knowledge. And there are solutions in relation to how we want to actually portray the community mobilization for better understanding of things. So how we have also scaled up this project. We have worked with other organizations, working with schools in Kerala on mental health championship in school programs, and also promoting mental health literacies in frontline public health workers with the Public Health Research Society of India, and also scoping of mental health literacies in community mental health services through the Foundation for Medical Research in Mumbai, based on the kind of community mental health and family care services in rural Satara. And also mental health and well-being of informal carers in urban and rural Delhi with the Public Health Resource Society of India. So the work kind of carries on as to how we actually incorporate that into the practices and policy-making processes. And there are a lot of resources that we have actually made through the theater pieces, and also about 12 to 14 films, and there are about 10 digital stories they're all available on the May Help India website. So namaste and thank you.
Thank you. That was a wonderful presentation, Professor Raghu.
Thank you.
Great.
Over to you, Kirit, please.
Yes, again, thank you for the work you're doing in Kerala. Sounds very interesting, and obviously some of the other parts of India, which is it's great you're mobilizing communities, which is the theme of this year's mental health awareness. So excellent, and obviously we have got questions from various people in our room. So what we're going to do, if it's okay, are you okay to stay with us for a little while, Professor Raghu?
Yeah, that's fine. Yeah.
Okay, so we'll get Amrita ji invite our next speaker, and then we'll have some questions later. Thank you.
Yeah,
Okay.
yeah, definitely. Thank you, Professor Raghu. Please stay around as we move to India and welcome Dr. Ramajayam. Before we chit-chat with him, we would like to also share with our viewers our future episodes as well as events which are running at different partner channels on Facebook, YouTube, and here we go. So on the next Sunday, the 25th of May, 2025, we will be having a yoga and meditation episode for body, mind, and soul from 2 p.m. British Summer Time onwards. And then the next Sunday, as we all are celebrating and working on cancer care and awareness special episode on 1st of June, 2025, from 2 p.m. British Summer Time onwards. And we would also like to share, gladly being a part of Indian Knowledge System, our upcoming conference at IIT Mandi on Mind, Brain and Consciousness, which will be held from 4th to 7th of June 2025 at Indian Institute of Technology, Mandi, Himachal Pradesh, India. And I also gladly, warmly welcome all of you to be a part of this conference and witness where we do a lot of work, and we have Professor Ramajayam who can shed some light on that. And the conference will be on various themes. We'll be touching on different themes, and we expect guests as well as other dignitaries in the field of mental health and cognitive science, holistic healing, and many other platforms who will be addressing this conference and making it a memorable event. So as we go further, it's time to welcome Professor Ramajayam. Dr. Ramajayam is a faculty at IKSHMA, Indian Knowledge System of Mental Health Applications at IIT Mandi, Himachal Pradesh. He's a graduate with doctorate in psychiatry and yoga, and also has been working at NIMHANS, National Institute of Mental Health and Neuroscience, and S. Vyasa University, Bangalore, who he has expertise in EEG, fMRI, transcranial magnetic stimulation, and he has designed various yoga modules for psychiatric patients at NIMHANS. He is also a core group member at SPARK, which is Spiritual Applications of Research Center at Brahma Kumaris, and manages the Raja Yoga-based projects across India. And he has been practicing Raja Yoga since 2004. He has his expertise in the field of neuroscience, psychiatry, and has published various articles in high-impact, peer-reviewed international journals. Most welcome. Thank you.
Thank you for your kind introduction, and good evening and namaste for all the panelists there.
So can you maximize your screen, please?
Yeah.
Thank you.
Yes. Is it okay now?
Yes, sir. Thank you.
Yeah, thank you. So for the next 20 minutes, I'll be just sharing my experiences and whatever the learnings I've had till now on this topic, stress to strength and building mental resilience. So before I get into this topic, let me just give a context. Why did I choose this topic basically? So we all must be very much aware now. There is a lot of uncertainties everywhere, wherever you go, whatever the field you are in. And because of this, mental health related issues are growing like anything across the globe. And I would also like to say that it's almost like 1 in 20. For every 20%, you definitely come across one who is having clinical depression currently across the globe. But when you look at the resources that we have, especially human resources in terms of psychiatrists and professional services that are available, we do not have enough. And we have witnessed this especially during the COVID time. So though everything was happening just right in front of us, we could do nothing. We could just see only people dying in front of our own eyes. And this is just only a rehearsal, I would say. There is a lot more to come like that in the near future. And most likely, all of you who are sitting here would agree with what I'm actually trying to say. So in this context, on one hand, yes, definitely we need to get equipped with different kinds of high-end technologies in terms of treatment. There is no doubt about that. But on the other hand, just like the previous speaker was pointing out, it's right time for us to talk more about health rather than discussing in detail about ill health and disorders. We have actually enough to talk about disorders and disease, but almost we have nothing to talk about health in general or well-being particularly. So that's the little bit context why I have chosen this topic, even though this topic seems very, very familiar. For example, if you just open YouTube or if you just go to any kind of this self-development lectures, most of the people would definitely talk about this thing called as stress. So it's such a familiar topic, but still I have chosen this because we only hear this, we only talk about this, but we actually do not do anything about this at a personal level also, and at a larger level in terms of society as well. So these are some of the different institutions with which I collaborate, particularly through this thing called as a Spiritual Applications and Research Center. It is associated with Brahma Kumaris, which Dr. Amrita was introducing at the beginning. So mainly I work with the different kinds of meditations and then yoga related practices, particularly in the context of mental health. So, but I'm not going to talk much about technical things or more in terms of science, because I know the audience for whom we are giving this is more of general public. So I'm going to talk more in terms of plain terms, though it might have some kind of scientific background behind. So before I get into this thing called as a stress, what is stress basically, or what is resilience? I'd just like to bring some of the universal truths which are actually related to stress itself, which all of us know for sure, but I don't know how much we actually recognize this. So the first and foremost thing is problems are everywhere. If I ask this question, is there anybody here who says, I do not have any problematic situation in my life? I'm sure nobody will have the guts to tell this, I don't have any problematic situation in my life. So this is the first universal truth related to stress. Is there anybody who wants to disagree with this question? Is there anybody here who says that, no, I don't have any problematic situation at all?
You're correct. Nobody can
Okay.
disagree.
Yeah. So this is the first universal truth. The second important universal truth related to stress is problematic situations will keep increasing. Every day it keeps on increasing. Is there anybody who wants to disagree with this thing? I don't think anybody would disagree with this. The third universal truth is problematic situations, they keep coming in very, very new formats every day. It's not the same pattern that keeps repeating. So say, for example, the kind of problems that we face today in the name of digital technologies, we would have never imagined also. So such kind of things will keep coming, which is going to be very, very fresh. And this is the third universal truth. What are the problems that we face or that we are going to face? They are going to be definitely new. They are not going to be some old fashioned, what we have already seen. So these are the three universal truths which I would like to first of all make all of you recognize related to stress. One is problems are everywhere. Second is problems they increase. And third is problems are always new. Now, with this thing at the background, I would like to ask you this question. When you know all these three things are true and you agree with this, then what do you mean by I don't want stress? There is nobody here who is disagreeing with all these things, these universal truth, what I put in front of you in the name of stress. When you know this beforehand and when you agree with this, then what do you mean when you say, I don't want stress? It would be more interesting if it is more interactive.
I've got a question
Yes.
over here. I've got one small response. I've got a slightly altered vision. It is
Yeah.
not the problems which are everywhere. It is actually I am the problem. And it's looking into oneself. That's possibly the cause of majority of the issue.
Correct. Yeah. You have directly jumped into the solution. Yes, I do agree with what you say. True. So, keeping those universal truths at the background in the context, I would like to define stress as a pressure upon resilience. This is actually a borrowed concept from physics where they define force per unit area. So this can be actually tweaked for stress also, for defining stress in a more practical terms. So what we have seen in the previous slide, it's all about the numerator part. And as you rightly pointed out, the problem is actually not the problem itself. It's we who is facing the problem are the real problems. So in that context, all that we can do, if at all we want to work with stress, is don't touch this numerator part, because that is not at all in your hand and you cannot do anything, because situations will remain just like that only. That doesn't mean that you need to suffer. We have actually enormous amount of resources within us. What we can do with that, that is the only thing which we can do if at all we want to work with stress. And that is what is actually shown in the denominator part, which is actually resilience. So this is where the role of yoga, meditation, or what are the kinds of similar practices that comes in your mind. Everything plays a huge role in the name of well-being. And all the kinds of Western medicine related concepts, whatever we have, they do very, very little or almost nothing related to this denominator part. And in fact, it is very, very sad to say this. even though we have been working for so many years, so many decades together, we are still struggling to define what is health, what is mental health. Why? Because it is easy to define disease because it is very florid and you can just count the symptoms and then you do some diagnostic test, then you arrive at the diagnosis. Whereas when it comes to normalcy, it is so varied and it is very, very difficult to define. And this is the problem with which Western medicine actually is finding very, very difficult to manage basically. And it's not actually difficult to manage, it is all about mindset. If you can just try to understand yourself from a different perspective, it's definitely possible to experience easily, even if we cannot define what is normal. And if we just bring that kind of mindset, only then this concept of resilience comes, and only then there is scope for us to think about and then work around this concept of resilience. And it is very nicely depicted here through these two images, what it means when we say resilience. So when we talk about stress as well as resilience, to me, it is actually just one and the same. They are not two different things, basically. I'll try to explain how it is actually one and the same. So here first, I'm just trying to show you what is this stress response. So stress response, as we all know, it is actually very important for our daily day-to-day life. Say, for example, if you're just walking along the road, all of a sudden a snake comes, you have to actually run away from there if you want to save yourself. And for that, you need to spend more energy. Your heart has to beat fast. You need more oxygen. You need more blood circulation. You need more energy. So it is an inbuilt mechanism. But the problem is, yes, you have crossed that stressful situation or that crisis, but after that also, if you are still responding in the same manner, that is where the problem begins. It is just like, for example, you're just riding some vehicle. For some reason, you wanted to just speed up, so you just press the accelerator. But after that, when you're trying to release the accelerator, you are not able to release. That is the most dangerous situation. So this is exactly what happens with our daily day-to-day life. Somebody just told something and it just got over in a minute or so. But you keep rewinding the same thing again and again for almost like your whole lifetime. And that is what is actually shown here as a prolonged response. And then it becomes a problematic stress, which we call as a chronic stress. So if you just overreact, that is also a problem. Or on the other hand, if you just try to run away or if you just try to freeze, that is also a problem. And this is what most of the times we actually do. So this is the part related to stress response. What about this resilience? As I was telling, it is actually just one and the same. They are not two different things. We can actually talk about resilience only in the context of stress. You cannot define what is day if you do not know what is night. It exactly is the same thing here also. When we say resilience, it means that at times of adversity, how do you respond? How do you spring back? How do you challenge them and then you recover? So this is all about resilience basically, and it cannot be talked about without the context of stress. It is in this context I was telling stress and resilience, they are actually just one and the same. If you have good coping mechanism, if you have good coping skills and you come back to normalcy, then you are resilient. But for some reason, if you do not know how to cope up with all the different kinds of challenges or adversities that you have, then you prolong the stress response, and that chronic stress leads to ill health, disease, disorder, everything. So putting all these things together, this is how I can just represent in one single figure. Any kind of challenge when it comes in your life, you may perceive that as a stress, and your body actually responds. The response that your body and your mind is giving is actually very much required. But what is problem is, are you sustaining that stress response more than required? That is where the problem begins. So if you are able to stop immediately after the crisis over the stress response, it means you are becoming actually resilient, and the response that you are giving is actually an adaptive response, not a stress response. So this is what I call as two sides of the same coin. So if you know how to cope with things, then you can actually build a very good adaptive response and you can become resilient. Otherwise, you are choosing to suffer. There is no other way out. So to put all these things in a concept table, this is how I can actually tell you the difference or the similarities between stress and then resilience. So it's all about only two things. Even if you do not understand what is there in this table, it's about two things. One is perception, another thing is training. So if you are actually subjecting yourself to stress and then suffering, that is also because of your perception, and you're training to suffer. You're training yourself to suffer. And if you are actually knowing how to cope up with things, and if you are becoming resilient, that is also because of your perception and your training. So it's all about only two things: perception and then training. So what is this perception and then training? If at all some situation is coming in front of you which you think is stressful, you are actually fixing yourself to see that situation in a particular format. That's the only meaning when you say it is stressful. There can be 100 different ways of seeing the same thing, only if you open up yourself, only if you keep your mind open. Otherwise, it is going to be only that fixed perception. That is where you feel something as a threat or a pressure or a tension or a stress. I can just illustrate this with a very nice example. Say, for example, let's say there is a boss, okay, and there are some 10 workers working with the boss. First person gets into the boss chamber. Boss shouts at the person for no reason, and then the first person comes out. Second person goes. Same room, same boss, same wordings, a similar kind of tone, shouting, everything is same. Second person comes out. Third person goes. Same thing. All the 10 persons are entering into the boss room, and the boss is shouting with the same tone, same anger, same words, exactly same repetitions. Now the question is, do you think all these 10 people would be stressed? Yes or no? Why? If yes, why? If no, why? Yes, anybody?
I've got one point to say there again.
Yeah.
I'm glad to see that you had been working with DRDO. One of the interesting
Yeah.
things that we knew in the army, that once you go inside the commanding officer's office, you'll be shouted at. So we were
Yeah.
quite pretty well trained in that. We could come out without any concern that we had gone there to be shouted at, and we came out hearing the shouts, but not to bother at all about it. It's again a question of training, and you know what exactly it means to be shouted at.
Yeah. So when we say it's not definitely that all those people who are entering there are going to be stressed, it means one thing which is very, very clear. The clear message here is the thing what we are calling here as a stress tension is definitely not somewhere outside, whether it is boss or whether it is situation, whatever you want to call, whether it is climate change or whether it is COVID, it's not at all there outside. If we say no, no, it is there outside, then definitely all these 10 people who are entering inside should come out with the same response. And the response is stress, tension. And it never happens. I'm sure all of us would agree with this. So this gives a very clear, strong message that stress is purely a perception. And if you want, you can see it differently. And it is definitely 200% your choice. So if you choose to perceive it in a different way, where there is no stress, only then comes the chance to train yourself to become resilient. And training, it's all just the question of time and commitment. And if you have these two things, definitely it is guaranteed you cannot suffer unless you choose to suffer. So the essence of this slide is it's all about only perception and then training. If you want to perceive stress, it's your choice. If you want to pursue, yes, there is some other alternative way to cope the same thing. Again, it's your choice. And based on the choice that you opt for yourself, you're going to train yourself either to suffer or to become resilient. So choose wisely. So that's about the talking part or the discussions which I want to bring in front of you all. Now, okay, let's little bit see about what to do with these stress or tension. What can we do about this? I just want to play one small video. It's just few seconds video. After that, let me ask you one question.
Dr. Rama, I've broken your screen. We cannot play anybody's copyrights. And that
Okay.
doesn't belong to us. In future, please be mindful. Hopefully, we don't get stuck. The moment it becomes 10 seconds, we cannot play anybody's copyright. But carry on, yes, it's beautiful.
Yeah.
And we can
Yeah.
chit chat with our doctors here and the audience.
Yeah. So the question is, just a sec.
Thank you, Dr. Ramajim. This was such a wonderful and a sweet, I would say, presentation. Meet Dr. Anukul. You will be meeting him at MBCC also. He's coming all the way from London. So,
Yeah.
yes,
Yeah.
please go ahead.
Yeah. So the question is, if somebody wants to actually take all the services successfully, where should that person stand in the court?
Near the net.
Near the net, okay. Any other reply? Yes. Yes, please. Somebody is raising the hand. Yeah.
Lata, come here.
Hi.
Lata ji.
Hello, everyone. My thing would be to do a ace when you hit or at the corner where you start serving.
Okay. Fine. So I'm not going to answer for that. I'll come back to that answer later on. So to answer that, I'm just going to ask you one question. It's the simple question. I've already put it here. I'm just asking you, what is this? The image that is shown here, what is this?
Microphone.
Yeah. All of you agree with this answer? It's mic. Okay. So I'm going to ask you the same question once again. Suppose the audience here, they do not have this thing called as microphone in their vocabulary. I'm asking the same question. What is this? I'm just saying the word mic is definitely not the stuff which is actually in front of you. It's just a word which is representing. So if there is no such vocabulary called as mic, I'm asking you this question. What is this again? Yes, please.
Is it a
What
trick
is
question?
it? Yeah. Maybe you would start describing what it is actually. Again, I'm going to, yeah, yes, please. Somebody's raising the hand.
It's an object.
It's an object. Okay. So you started to think in the direction which I'm actually expecting. Fine. Now the question again is, you might actually try to generalize and then answer, okay, it's a device which can actually amplify your voice. But the question is, you want to convey the message about this stuff specifically, because there could be many other stuffs which can actually amplify the voice. But I am asking you to convey about this particular thing which is in front of you. What is this? So if you just keep asking like this, it's just a very simple question, but with profound reflection, if you just think about this, you have the solution for the previous question what I've asked. Where would you like to stand in the court? The answer is there is no particular place where you can actually stand. It depends on the person who is actually serving there. But one thing which we can actually tell very clearly is you need to stand in a place where from you can take all the services properly. So in the same way, if at all, if you want to actually manage stress and if you want to become resilient, the key thing that we need to actually develop is understanding about who is this person called as me. For example, the word Mike is not really Mike. We know that very well. The descriptions about Mike is not definitely Mike. It's something else completely different. But we actually, day in and out, we keep using the same thing like, no, it's Mike, that is the mic. No, the descriptions about the mic is that actual stuff. I hope you are understanding what I'm trying to convey. What I'm trying to convey is life is basically a bunch of 100 different kinds of relations or different kinds of roles that you play from morning till night. You might be actually a husband when you are at home, or when you are at office, you might be a boss, or when you are in university somewhere else, you might be a student. But just ask yourself, are you just clinging with the word Mike, or are you actually being that stuff who you are? The answer is definitely we are clinging to the words, the descriptions about ourselves, not really with our own self. So whatever the kind of strength that we actually need to develop this thing called as a resilience, it lies deep down there when you can peel off all these kinds of things that you think you are, which actually you are not. And this is what I mean as centering yourself. With that centering, if you just try to start living your life, you can actually be with all the kinds of roles, all the kinds of relations, exactly to the level that is required, to the point that is required, but still you would actually center yourself and then remain with that happiness, with that peace, with that love, whatever it is required. And this is the question which I was asking in the previous slide. Where would you like to stand? So you need to center yourself. When I say center yourself, it need not be the geometrical center. It's the center where from you can reach out to any place comfortably, not only reaching out, but also coming back, because that is also equally important. Because the next service where it will come, you don't know. So in this context, just compare exactly that tennis court with your life. Where are you centered? Are you centered in a position where from you can reach out and then come back comfortably? Or you can only reach out to a place, but there you are stuck? Or you don't even want to reach out in the name of centering, you are stuck somewhere else? So if you can reflect deeply on this, I'm sure definitely you would develop what is this thing called as resilience. At least you'll take efforts in the right direction. I can guarantee you. So this is just not a philosophy what I'm telling. This is almost like 21 years of experience in the name of meditation, which I have been practicing. So I think with this, I would like to stop here because I've already crossed my time limit. So what are the kinds of roles, responsibilities, relations, all that we have? It's very, very important because life is that. But in that very name, if you're getting struck, it also means there is no life because you're choosing yourself to suffer. So all those relations are connected with this thing called as body, which is shown on the right hand side. If you center yourself with this body, it means you are choosing yourself to suffer in the name of stress and tension. On the other hand, if you try to center yourself with that core self, which I'm showing here in the form of some light, just pictorially, I want to show that's it. If you can anchor yourself into that core self, I can guarantee you, you would definitely become resilient. You would definitely discover all the kinds of coping that is required for any kind of situations that would threaten you. And you can successfully manage all those things. So with that, I'll stop here. Thank you.
Thank you, Doctor. Very great to kind of bring in the kind of mindset in terms of how we work with our minds, because that's also the challenge in some of us who are having hectic lifestyles. It's sometimes our mind is very fluid in terms of having that to rest and take time to. So it was interesting the concepts you were bringing in. So any questions we have in terms of from can we bring Professor Raghu in as well, and we can bring any of our panelists as well who are still here with us. And any questions from our members as well who have joined us. So from your kind of perspective, Dr. Raghu, Professor Raghu, how did you find Dr. Jayan's presentation, and also some of the work you've been doing in terms of, you mentioned in Kerala, is there any crossover in terms of the theories and the concepts?
Yeah, I think it's an interesting presentation, Dr. Ramajayam. And I think it's in relation to the kind of the stress and resilience model, really. And I think, as you rightly put it, does anybody have any, are there anybody without any problems? Yes, there isn't anybody in the world without any problems. But I think the thing is that mental health is all about how we steer clear and how we create a pathway amongst all the stress and tension that we actually experience every day. Because there is, I think it is not like, I think people often sort of misinterpret the health dimension as a kind of a mobile phone. This is not an on and off button here. I think it is actually a constant button where you actually have to go through it, regardless of whatever, rich or poor or wherever you are. You have to actually go through it. That is what life is all about. That is what the Indian philosophy actually teaches in many ways, in the yoga, meditation, and those kind of contexts actually communicate the Indian psychology, as they call it. But I think but we never called it Indian psychology because we didn't. It's not because we didn't know that it was Indian psychology, because we didn't want to rebrand the Western psychology and the Indian psychology model, I think. Whereas I think it is more about ourselves. Because there is, I think, because there is old Indian philosophical statement that if you know yourself, you know everybody else. Because it is the same emotions that goes through everybody else. It is the same, context might be different, perspectives might be different, but it is the same emotion that goes through everybody else. I think the interpretation of it is also quite crucial. So I think, from that perspective, and I think the model is very attractive. It is highly philosophical, but I think, and again, the resilience. The thing is that many people are resilient, and I think the kind of looking at, I'm not politicizing it. People, the experience of the Gazan context at the moment. And I think people are highly resilient there. And how it is much more, I think there is another terminology, much more than resilience as well. And then how people construct that process. And I think that is what mental health is all about. And I think that's what we actually say about the mental health dimension, the way we offer mental health services. It is time that we moved away from the deficit model of mental ill health, of only classifying people into symptoms and diagnostics, into more about the health. I'm not saying that the diagnosis and the symptoms are important. They are important, but they are not the be-all and end-all of everything. Health comes first, and people don't know what is mental health. In the first instance, if people know what is mental health and how is it that we can construct that mental health, and I think then the communities will be much more easier and accessible, and then they're much more tolerant in the way how the health systems actually work.
Yeah.
Can I also bring in Judithia, who had her hands up? So you have a question? Any?
She did have a question, but the video is not on, so we can't spotlight her.
Okay.
It's a good conversation. A note that I would like to bring over here, Kerry, So Dr. Rama, very good. Dr. Raghu, fantastic. Dr. Rama, it's very important, and to everybody listening, if you ever identify anybody who is either going through stress or depression, please listen to them. They are trying to reach out to you in a different format. They are not
Yeah.
wrong. They don't know how to, because they might be at a point of suicide. And if you give them a lecture, don't be stupid and don't be this and nothing is wrong with you, that is not the correct thing. Do listen to people. They might be at a point of breaking and is trying to reach out to you. Dr. Rama, your questions were correct. However, there were no correct answer depending what level of professor or who was down here. If you are playing tennis and Roscoe Tanner is serving to you, then you don't stay at the baseline. You have to stay 2 or 3 meters away because he was one of the fastest server. However, a very simple answer would be in a single squat, bank center gives you opportunity to reach maximum that you can. So yes, your point was correct where you were leading. It's wonderful that if we come with examples, then people can learn. So our people who are in social media, there is one question where Professor Raghu, you and Dr. Rama may be able to answer. How you as an individual know that you are at a breaking point? Dr. Raghu, Professor Raghu, you go first.
The question was in relation to how the social media, what was that? Mentioned.
So we are not a webinar here. This is Healing Our Earth, where we beam onto several partner channels on social media and website. So the general comments what people are asking, in putting it in a simple format, they want to know, how would you know that you are at a breaking point? They're
Right.
asking in different way, different people asking differently, but roughly that's what they're asking.
Okay, right. And I think the thing is that the way from the psychological perspective, that everybody, I think the kind of well-being, everybody actually experiences tension, everybody experiences distress. And I think it is when you don't understand that distress, it actually, for a prolonged period of time, that distress becomes an illness. So I think the distress mode is when we have to actually try and understand. I think that's where some of those kind of what Dr. Rama mentioned in relation to the yoga, meditation, and all those kind of self-help approaches, exercise, and all those things would actually help to construct and create that process. So it is important. I think the essence here is not, especially in the world today. There is ample note about young people who actually have about 3,000, 4,000 Facebook friends, but they're still feeling very lonely. The thing is that it is not externalizing. We have to look inside. The problem is actually if the distress is actually you, and how do I overcome that distress within myself? And I think it is you and you alone who can actually address that. These other people can point things at you, can provide the right kind of approach, right kind of support, right kind of advice, family, etc. But one has to work at it. So we are all responsible for creating our own health and well-being. That is first point. It is nobody else's. A psychiatrist only gives you medicine and provides an advice, or a psychologist provides the advice and the medicine. But you have to work at it. Just looking at a bottle of Prozac alone will not create wellness. You have to work at it. So I think it's important that's where the community mobilization comes in. That's where your family mobilization comes in. We have to work together. This is not just paracetamol. This is much more than that. This is where we have to actually think about things. We have to talk about it. We have to bring other people into that perspective. We have to hear other people's perspectives. We have to act on it, and we have to construct that thing ourselves. And you alone has to be taking that action along with others.
Thank you, Professor Raghu. He mentioned very clearly, community is also important. Work together. If you feel you are going through depression, or you feel you are stressed, reach out to your closest people, do declare or talk to them. You might find it eases off if somebody listens to you. It may help. Rosalina is asking a question, and Rama, maybe you can answer. She's
Yeah.
in Italy and saying, whenever she stress, she has noticed she sweats. Is that normal symptom, physical symptom of stress?
Yeah. So before answering this question, let me briefly tell about the reply for the previous question as well. In simple terms, whether somebody is at a breaking point or not, how I would usually recognize this, it is like if I feel too much demanding and I feel like I do not have enough resources to manage the demand, this is where I would feel okay, I am actually just at the tipping point. Again, it's not necessary that everyone should respond in the same format. Say, for example, the second question, one might be actually responding with sweating, other person might be not at all responding anything physically, but still they might be at the level of just committing suicide. So it requires a lot to actually perceive what is going on exactly and then take the right decision at that point. As you rightly said previously, yes, I agree 100%. Depending upon what the person needs currently, we definitely have to give them what is required immediately. So this titration part, okay, what is required for whom has to be decided just by seeing the person right at that moment. And the trickiest thing there is it's not necessary that everybody is going to respond in the same format. And if you're a good clinician, definitely you will have that skill to spot right at that moment. And maybe for someone it could be ECT which has to be given right away, or for somebody it could be some other kind of emergency procedure, or for somebody it could be just like there is nothing actually, you just have to reassure them. I have seen all these kinds of patients, and it definitely requires a skill. And if you want, I can actually extend the answer. The other kind of patients whom we see these days, I would say, like, it's not actually the problem of the patient, it is actually the problem of the physician, I would say. It's not to discourage anybody, because everybody has their role and everybody has their own place. I'll give a clear-cut example. Somebody comes and then they says, I had actually gone for, let us say, some 2 weeks or 3 weeks intense meditation practice. I don't want to name what kind of meditation. Okay, let's say the guy is actually in IT industry. And immediately after that, he comes and then gives the symptoms like, I'm not feeling as if I'm grounded. I'm hearing some voices. I feel like I'm actually suspecting people that they might be doing something against me. Now, right the moment when somebody listens to this kind of symptoms, who is very well deeply trained just to only in Western medicine, let's say psychiatry, first and foremost thing they would do is they would just start prescribing right away some medicines. What I would like to clear here is it's not actually necessary, especially for this scenario. Why? Because the problem the person is actually going through, you may actually define that something called as a spiritual psychosis. And the spiritual psychosis, what he or she is going through, doesn't require medicine. Still, you have some enough time window to just give them some other kind of intervention. And the intervention is all about making them understand you are actually living a kind of haphazard life, let us say, whatever the hectic life you have, and you think you are living actually that kind of life for, let's say, 20 years. And you think you can just calm down yourself by going into deep silence, no mobile, no phone, no talking, nothing, just intensively for 3 weeks. And this can create a lot of confusion, and the confusion is actually the psychosis. If you can just make that person understand this, what somebody might be going for, let us say, ECT or some other kind of antidepressants, whatever it is, or tranquilizers, can be very well avoided. So it is
Thank
in
you,
this
Dr.
context,
Rama.
it's not, yeah.
Thank you, Dr. Rama. We've got to move on because we've got people and also the next person, Kirti, who will be
Yeah.
talking. Kirti, can you make your video landscape, please? Like how everybody's is. So it will be nice. Judith, let's have your question and then we move over. Judith, your question in USA. Over.
Yes, hi. Thank you so much. Everything was like really wonderful and clear and simple, I'm sure, for a lot of the audience. So here's the question. When you, in your mind, a lot of us, the reality is this: we are in our minds. We're not in the mind of the person that's next to us. We are in our minds, our own minds. So when we're going through stress, when someone is going through stress and the body's reacting and they don't understand exactly, your body's telling you you're stressed. Either you're breathing hard, or you're getting a headache, or whichever, or you feel like you're about to pass out because you're panicking, right? How then do you slow down this process? Because I think that's where a lot of people, they can't catch it before they get there. They only understand that they're under stress when they get there. Am I making sense?
So
So
how can we avoid getting there? Judith, you're asking, how can
we avoid getting there? But how can we, once we get there, how do we not let fear exasperate it to the next level? How do we slow it down?
So Professor Raghu or Dr. Rama, one or the other, please go ahead. Over.
I think the easiest, let me just go with the easiest way of doing it is in relation to, how do you manage that? First of all, I think in terms of having concentrating on your breathing, your understanding, slowing your breathing is actually the key in relation to how you might actually try and not react to that, and understanding that process a bit more. As to why, what is actually happening to me. And I think focusing on your breathing, concentrating on breathing is the first step in relation to sort of having a better understanding of what is actually going on within yourself. And I think that in turn would actually help you to cognitively restructure or rewire the process of thinking as to what I should react, or your panic situations, or your fear, or whatever. I think it naturally slows down that process and creates that inner understanding as to, I need to be calm here. And in relation to it, I mean, I do that every day. In academic circles, you have a lot of people like they challenge you and other things. So rather than overreacting to many of those situations, I feel quite anxious sometimes when those people ask those questions. So I think you naturally think, should I react to this or shall I not? Shall I wait for a while? And shall I just think about what I need to say here? So I think taking a step back sometimes is actually often most helpful in relation to understanding what is it that you're trying to react to. What is your position? The problem in the kind of the anxiety kind of context and the fearful context is that, when one is not control of what is actually happening, one is not understanding what is actually happening inside you. And I think as a result of that process, you feel overreacting, and the anxiety and everything else, the physiological mechanisms and the psychological mechanisms interplay here is overtaking you in many ways in terms of not actually having an appropriate reaction. I think the simple answer to the question is that if you can focus on your breathing, if you can slow down your breathing as a first measure, that would be a first step in the right direction of understanding.
Thank you, Professor Raghu. Very simple, as you said. See if you can breathe your way into it. Hydrate, meaning drink some water as well. Water is the first thing you hit at, because when you are not hydrated, your mind is not happy, things are not happy. Breathe, step away from the situation, and very important, the moment you condition your mind that you have a problem, you are in a problem. But if the problem is an opportunity to find a solution, then you are a powerful person and you will find things ease off. We need to move on. Judy, stay around. We'll come back to you. Rama, stay around if you can. We need to move to our next guest who has been waiting patiently for 20 minutes. We'll come back to all of you. Kirit, let's introduce Kirti, and if you can convince her to be landscape, please. I don't know whether she's getting our sound or not. Over to you, Kirit.
Okay, thank you. Guest stay around. This is the next speaker who's coming from Mumbai as well. And again, it's this Gizajia Mehra who I've met and doing some fantastic work. If you can change your phone to landscape, that would help, because then we'll see you clearly. But while you're doing that, Gizajia has been a social worker for 29 years. She's founded an organization called the Ish Foundation. She spent over 30, she works with 30 plus NGOs over Maharashtra, and got accolades in terms of recognition from the Mumbai police as well for the work she's been doing. She's very busy today because she's actually campaigning as well, so that's why we're privileged to have you here. And without further ado, just tell us more about the work you've been doing. Particularly, you've been doing a lot of work around empowering women and the community campaigning as well, but most importantly, the work you've seen through the women around their mental health challenges that you've come across.
Is she hearing us? I don't think she is hearing us, Kirit.
Can you hear us?
या नमस्कार जी।
नमस्ते नमस्ते।
मैंने पूरा सुना है अच्छे से, मुझे बहुत अच्छा लगा। हमारी संस्था भी यहाँ मेंटल हेल्थ अवेयरनेस के लिए काम कर रही है। उसमें हम उनके साथ जो शेयर करते हैं ज्यादा बातें, हम उनको बोलते हैं कि उनकी सोच जो है वो पॉजिटिव होनी चाहिए, वो अपने कॉन्फिडेंस उनके अंदर होना चाहिए और पॉजिटिव एटीट्यूड उनको रखना चाहिए। क्योंकि कई बार हम दवाइयों से जल्दी ठीक नहीं होते, अगर हम किसी को मॉरल सपोर्ट देते हैं तो हमें अच्छा ट्रीटमेंट मिलता है। अगर हमारी फैमिली हमारे साथ होती है, हमारा समाज हमें साथ देता है, तो हम जल्दी ठीक हो सकते हैं इन सब चीजों से। सॉरी, आज मेरे पास टाइम नहीं है क्योंकि मैं यहाँ हंगर स्ट्राइक के लिए बैठी हूँ इंडिया में, क्योंकि हमारा जो एरिया है वो नो लिकर जोन डिक्लेयर करने के लिए हम गवर्नमेंट से डिमांड कर रहे हैं। तो मैं आपसे इजाजत चाहती हूँ। थैंक यू।
Okay, thank you. Dhanyawad, Kirti ji, and we'll touch back with you again. So, Kirit, she's on a hunger strike over there where she's not able to communicate. Let's move on to Anupul and Judith and Professor Raghu. Let's chit chat because what a wonderful subject we have chosen to the mental health awareness. How we can help people, how we can bring a bit of stress-free life in people's life. So breathing is very good. If you are suffocating, you are stressing. Anukul, you had a point, and we'll go to Judith because she wanted to make a point.
Yes, absolutely. Thank you very much. Thank you very much. Now, this is something about, I just wanted to talk to Dr. Raghavan, and that is about the comments that he had made about the system within the Kerala and other places as well. And it's absolutely fantastic because they're very consistent with what I was expecting over time. In reality, when you said when it comes to what you call literacy, it's very important to note that it was sometime around 1815 or 1820. The literate Indian, which was approximately in the range of approximately 85 or 90%, were suddenly turned into 5 or 7% when the Macaulay's system had come in. So literacy fundamentally means that how well you are bound to a normal cultural and social system of language. But once they introduced English as a system of saying that this is what literacy means, ultimately the 85 literate people, 85% became 5 or 10%. So that's where the major issue comes. To that extent, please correct me if I'm wrong or correct or whatever it is. My general approach of understanding it is, if you take the Vedanta system, I say there is something called natural, what is absolutely natural. And whether nature comes in conflict with the social and other environmental issues, that's where the sort of called neurotic symptoms and other kind of depression, anxieties come in. Am I correct in assuming that?
Well, I think I think in a way it is right, but I think it's in relation to the kind of the literacy element. I think especially in the Kerala context, the health literacy in terms of access to the physical health issues is high. Because of the social transformations that have taken place over the last 40 years in terms of education, in terms of primary health care in every nook and corner of Kerala. But the stigma is so profound in relation to mental ill health. So the question that I'm asking is, because even though there is higher education, the so-called Western model of education is very highly there, but people are not thinking about the stigma is so prevalent. So highly prevalent, even in the educated classes, really, not in the kind of rural communities. Actually, in the rural rural communities, the stigma is lower rather than the kind of educated classes. So I think so. It is whether so that is what we need to try and think about. The kind of awareness and the mental health literacies is what I call that we need to promote the mental health literacies, because mental health literacy is not not just for the person who is experiencing that distress. Everybody is responsible for it, because the family has to first and foremost, the family has to support the person. So the family has to have adequate mental health literacies to actually support their son, daughter, or whatever relative that they have. The school kind of context where there is actually undergoing severe pressure and transformations. And I think the teachers and everybody else need to actually have adequate mental health literacy to support the people. In the same way, employers need to actually have, there is the kind of so all those people need to actually have good understanding of what is mental health, what is mental ill health. That seems to be a big gap in both in the Indian context and also in the Western context as well. Really, it is not just purely an Indian issue. In the West, I think maybe we talk more about it, but we actually seek more medical help as opposed to the other kind of actually help. Whereas in the Indian context, people don't actually seek any help at all because we find it quite difficult to talk about it. We think the cultural scenario is actually such that we should not be talking about. Actually, culture is not the victim, the problem here. It is us, because culture always enables people to talk about different things. But I think the way we view culture, the way we view cultural heritage, and religion is not responsible for it either. And I think it is us, our own perceptions, and over a number of years, how we think that alone isolates us from other kind of stimulus. I think that is the reason why. And that is the reason why an individual and collectively we need to actually have that awareness and education.
Yes, Professor Raghu, that's exactly what I wanted to come for. That when it comes to literacy and the Western education that we've acquired in India, we are quite different from what we have been taught in the standard Gurukul system. So when you have in the Gurukul system, you tend to understand what is Manamaya Kosha, what is Jnanamaya Kosha, and those kind of things. When you understand what is the concept, how your mind works, how your process of thinking works, if you can understand the way your mind works, how you can inquire about your mind, how do you inquire about your thought processes, that is something which is not taught in our conventional systems, which is there very much in the Gurukul system, which has been eliminated from India. And that's one of the reasons why I'm very strongly in favor of getting to the Gurukul system, because you literally are looking into your own self and then trying to figure out how those thoughts are coming into your mind and why you're getting upset or not upset. That's number one. Number two is the concept of breathing that you said. I was quite surprised to know that in Gurukul system, in the first 3 years or first 2 years of Gurukul education, the first thing that you're taught is how to control your breathing, because your breath is life. And that breathing and life relationship and how it controls your mind is absolutely central to various issues, including the various kinds of what you call attention deficit disorders that you find in children over here, and the way they get diverted into various issues. It is something that has to be looked into very seriously, because I think the Ayurvedic systems and our conventional Indian systems have got huge amount of role to play in developing resilience. And another issue that I wanted to talk to Dr. Ramanujan was in the army with the DRDO, you're working with them. We used to have something called battle inoculation. We used to, in our medical battalion, we used to have that. And every once a month or every 2 months, we used to have 7 days of continuous putting the person under enormous amount of stress and no sleeping for about 7 days at a stretch. And it is at that time the seniors would make a judgment whether we as an officer are good enough to take decisions correctly and appropriately, because after all, you've got 600 or 800 or 1,000 people behind you whose life depends on you. But after 8 days of not sleeping at all and taking tough decisions and in a very crucial decisions, how you can train yourself. If you're not able to withstand that stress, you're not fit enough to get to the next rank, as plain as that. So that type of what you call battle inoculation is central to training process. And that happens even to as surgeons. You have to go through the training process repeatedly to see how best you can handle those tough situations, failing which you don't go to get your practice otherwise.
Thank
So
you,
that's the way I was
Surgeon.
thinking of.
Thank you, Surgeon Goswami. He's a very eminent surgeon, and Dr. Ramajayam, you are going to see him in the MBCC conference very soon coming, which at this point, before you comment, I want to bring that up because it's something quite important for those viewers who are listening over here. Something exciting happening at IIT Mandi, where we are proud to say our Dr. Amrita Sharma is there too. And this is taking place in Himachal Pradesh between 4th and 7th of June. 3-4 people from Healing Our Earth will be there. And it's organized by the Indian Knowledge System and Mental Health Applications, IKSMHA, quite well-known center, and IIT Mandi. I love the themes over here because they are so varied. Science of consciousness, Indian philosophy, neuroscience, theories and perception, quantum perception, cognitive psychology, cognitive biomarkers, science of intelligence, sleep and dream, wearable devices. So they are quite modern, Ayurveda and mental health. And this is the one I love, Indian performing arts, because we're always performing daily in our life, music and musopathy. So many themes over here. So it's such a wonderful, and it's a perfect time to give this a plug because this week is Mental Health Awareness Week. So Dr. Amrita and Dr. Ramajayan and Anukul Goswami, shortly, in a couple of weeks' time, you'll all be together. It's very exciting. So Dr. Ramajayan, are you looking forward to that conference, which is going to bring so many tips to human communities?
Yeah, very much, very much. Yeah.
And Dr. Raghu said that it's the power of the community, which is the theme for this year's mental health awareness, because they particularly identified we need to celebrate the power and importance of community. And community are essence. The South Asian community normally is a close-knit family where you are actually involved with a lot of people. It's a bit changing now with Western influence. And once you can open up to the people, either in the family or within your own community, without being judged. So don't judge the people who come to you. First, listen to them. You can very simply ask maybe simple questions, which are so easy that you don't actually judge them. You can be simple. How have you been? Let them talk. Don't prompt them that they are stressed and they are mental and they are gone. Maybe how is your stress level once it's been identified? Or maybe have you been eating and sleeping correctly? How is your breathing? So be gentle to them because they are reaching out to you. You don't know what they might do the following day. There might be no more. Judith, sure. Ask your question, Judith, and the experts will answer. Judith is our permanent member at Healing Our Earth in USA. What she does, she loves chanting mantras sometimes. Judith,
You
go and
love
ask
when
your
I chant
question.
mantras. Yes, I would love to hear. Thank you so much. I would love to hear. I'm so sorry if I mispronounced your name. Dr. Ramajaya.
Yeah, Ramajayam.
Ramajayam's
Yeah.
answer to my previous question, but there's something else. I started studying with Ravi Sri Shankar, and I started with the whole meditation and breathing and everything, and all hell broke loose because I had to literally. It was like I was detoxing, right? So now that I'm better at it, it's been over close to 8 years now. What I start seeing happening is the stress that my body picked up from childhood. I'm starting to notice it at certain time where I notice that my body starts to tense up. And I realized it was a time that either I was getting yelled at or I was stressing because of some crazy stories that were being told. And I would just say, wait, I know I'm not stressing. Why is my body reacting this way? So there are different types of stress, right? There's the mental, spiritual, and now the physical that I'm dealing with, where I need to detox from that particular to let my body know you're safe. So can we talk a little bit about that particular aspect, because there are different stages of stress that we deal with as human beings, and I think a lot of us don't understand that because we may be dealing with issues from our past or things that we picked up, like our bodies picked up, and um, it's making what we're dealing with right now a bit impossible because we can't differentiate between the different types of.
Yeah. So we can actually should I go? Somebody
It's
has raised
okay,
their
Dr.
hand.
Lakshmi. Dr. Lakshmi
Yeah.
Vyas will have a comment in a while, but Dr. Rama, go ahead.
Yeah. We can actually hide things in our mind, but we cannot hide things in our body. It has to definitely come out. So the first and foremost thing that we need to look for is there anything which is explicitly coming out through the body? Say, for example, sweating or whatever the kinds of reactions that some of you were already discussing. So if something is being expressed at the level of body itself, we need to think some kind of physical intervention itself. Physical intervention, I mean, I may not even go for, let's say, breathing. Breathing, I will keep it actually as a next option. I'll give an example. I was actually managing a patient with a panic disorder. Before even I tell her something about breathing, already she will be in cardiology emergency department. So actually, I don't have any time to even talk about breathing because she's already somewhere else. So first thing is we need to clearly understand how strong it is, especially things that they have been exposed to in their childhood days. The problem with that is they cannot consciously recognize that it is a problem because they have accumulated those things when they were not able to think independently. You can sort out things and then solve easier those that you have acquired when you have started to think independently. So in that context, whatever you have gathered in your childhood days, it will just hit you like anything, but you will not recognize that it is a problem from inside. And these are the things that would come out physically in a very strong manner. And for these kinds of patients, the first and foremost thing is we need to keep aside all the kinds of philosophies, whatever we have. We need to just give them the comfort first. The first and foremost thing that we need to give them is comfort and confidence. And in that context, the comfort and confidence, especially if it is like panic disorder, a panic attack, nothing works except benzodiazepine. It is just as simple as this. But if you're able to gain the confidence, say for example, this is how I started with. Initially, I started negotiating, but they were actually not willing to work on those lines. Second time, when they again developed this, before even I contacted them, already they were in emergency department, and then the husband was actually calling me. All that I had to tell them was, you don't worry, there is nothing to do with cardiology, but it is essential that you need to go through that investigation. And that is just for reassurance because they had already gone to some 4 or 5 cardiologists and this is the 5th time. So once you actually give them the reassurance, after that actually they come in touch with you. And from here onwards, I will keep the tranquilizer aside. It can be still used, but now my first priority would be actually breathing. And as they start working on breathing slowly and slowly, then comes the last part, that is dealing directly with their mind, the spiritual part. And it requires actually a lot more courage to see things face to face. And in fact, you might be actually getting confused if I say, what is the final ultimate goal of yoga? The final ultimate goal of yoga is to just break the walls between conscious, subconscious, and unconscious. Maybe it might look very new for you, maybe confusing definition, but this is the reality. And this is why we feel very tough to actually face the problem as it is. And that is the final resort. But if you really want to guide them, you need to just make them completely comfortable to bring to that level. After that, only you can actually guide them. I hope I have actually touched all the 3 levels, but in the reverse order. So
Thank you.
definitely.
Thank you, Dr.
Yeah.
Thank you, Dr. Rama. Let's take a comment from Dr. Lakshmi Vyas. Then we are going to welcome our senior host from Colorado in America, and we'll still continue the chit chat. Dr. Lakshmi Vyas, Global Namaste, and welcome to you.
Global Namaste to all of you. Very nice hearing everyone. Every one of you had your own opinion. I will tell something about what my experience was as a principal of a college and managing thousands of students within the college. So
we had a counseling section. So qualified counselors were there. They used to come twice a week to the college, and they would any student who had any problem or anything could go and talk to them. Usually the staff room was given to the counselors, and quite a few students used to hesitate to come in the beginning, but when the other students used to convey, oh, this lady does a good job, I'm very happy with her, so more and more students come. So over the years, so many years, the counselors are fixed in the college, and they used to come and talk to the students, and they somehow or the other, they used to get an immense relief. So over the years, they really develop into normal people, and this is what I have experienced. It takes about some of them improve within 6 months, some of them take 2 years, some of them even take 4 years. 4 years is the period the students stay in the college. So all the 4 years they are in the college, and by the end of the thing, even they come back and talk to the counselors. So a rapport is also built between the counselor and the student, and all these characteristics help the students to really win over the situation. Thank you.
You, Dr. Lakshmi Vyas, and of course, you've been not just a principal over there. Subsequently, lately, you are the president of the Hindi Forum of Europe. You meet so many people, and in so doing, you are also a calming, soothing personality that helps people. So now let's chit-chat and get some tips from people. We have identified what happens. But let's give people something to take back home. So those viewers who are connected to us on the YouTube, Facebook, website, social media, and our partner channels, welcome. Keep your notepad and pen ready. We'll try to share some tips with you. I will kickstart our panel. But before we do that, let's welcome Sharon Rose in Colorado, in America, who is our senior host and correspondent of Healing Our Earth in America. A global namaste to you, Sharon, and how are you?
A global namaste, Neil, and everyone. I'm good. I want to comment on what Judith had to say.
Go ahead, make your comment, and then we come back to the tips.
This is an area, the relationship between the thoughts, the emotions, and the physical body is an area I've been researching for many, many years, starting probably with my master's thesis many years ago. And what I discovered is that the thoughts themselves and the emotions connected have really an incredible impact on the physical body. And all of these patterns of protection, I would call them, especially us women, that we develop from very, very early on, create kind of armoring. If you know the work of Wilhelm Reich, that was my master thesis. I worked on his teachings. And so what happens is that we lock our bodies in order to protect them, really. When terrible things or even just disturbing emotions come at us, we freeze, we stop breathing, we lock ourselves in these patterns, and the patterns have a tendency, unless we, do a lot of different kinds of healing therapies, and really go in and look at what's causing these things, then they tend to stay with us throughout our lives and even cause us to have things like frozen shoulders. We lock these emotional thought patterns into our physical body. And so what helps me the most, of course, is, first of all, recognizing that that's what's going on, that it's a layer of protection that when you're older, you actually don't need so much anymore. It's actually causing you pain. And so it's like journeying into into feeling and sensing in to those areas in your body where you really are holding. Many of us women have a tendency to the psoas muscle contracts, and that it's like a fear kind of thing, right? And we're holding like this, and then our shoulders will come forward and we end up like this. And so what do we need? The first thing we need, of course, is a big breath and recognizing that. And if you're in that kind of, there are all kinds of yoga poses, there's Qigong, there's many things that can help us physically through it. But, and there's Feldenkrais exercises, which have really helped me. So if I'm feeling the stress and the years of reacting to what we might call the patriarchy, the male entitlement aspects, or even women have that, but it's this kind of like, oh yeah, I'm in charge and you're just the servant. That's happened to a lot of us women. And so it's starting to recognize when you're in that situation, watch your body, become aware of your body, and breathe and ground. And, you know, I will do things like, because of my training with my Guruji Sitara Devi, I will like feel myself, feel the power of Durga in that kind of situation, and feel that, and really stand in my own power and my own strength, and cause almost like an energetic protective field, which we call in Qigong the Wei Qi field, and let that build up. I even have in my forthcoming film, we even have some exercises that help you. Dr. Robert Peng, he says, put your hands in this mudra by your sides and then squeeze them, and it kind of pumps up your field. And maybe it's just that whole connection with the brain and the hands that helps you remember to ground, wake up, and breathe, and come into the part of yourself that has never been injured, the part of yourself that is always divine. And the other thing that when I'm doing my exercises, if I notice that I'll be fine and it's all fine, and then all of a sudden my mind is caught in some kind of loop of emotion, and I notice that loop of emotion in my mind is causing the tension in my body. So the minute I recognize it, I take a deep breath or a number of deep breaths and just allow it, feel myself relax, really allow one's body to just relax. So those are some thoughts for you, Judith.
Thank you. Thank you, Sharon. And one of the anti-stress buster for Sharon is her dancing. She releases any of her stress or any matters that bugs her through dancing. Sharon, I'm going to come back to you in a while, and then we will discuss further. And in about 10-15 minutes time, we're going to hit back to America with Eleni Anna Sofia, who is one of our guest contributor. We'll be bringing her. What I would like to do now, just everybody gets 1 minute in quick, sharp 1 minute burst. If you can give 3 to 4 tips for people, either as an expert to deal with others or others to ask for the experts. I'm going to start off and give my examples to you so you can see. So one of the things is when you talk to the people, avoid interrupting them. Don't rush them. Let them talk it out. Even if there is a bit of pregnant pause and a silence, Let them bird and let them talk out what they want, not what we want them to talk. And if you are concerned about their safety, then make a note of it. Give them contacts of the right relevant authorities within the region. If they are in UK, then it's different. If they are in India, it's different. If it's in America, it's different. Make a note of it. Maybe even if it's okay and the family had asked you to talk to their either siblings or sons or daughter, then inform them, because sometimes family don't take it too much, they take it lightly. And maybe also offer practical support. So those are like simple tips. Let's go and we'll go around and take some tips from people that can help either to talk to the people who might be suicidal or mentally depressed or stressed, or an expert, what they can give comments to. Let's go to our producer for today's episode, Kirit Mistry, there in Midlands. Now, one of the things he does, he runs SAHA organization, South Asian Health Action. He's a founder of it. And they do so many outreach on many health matters. It is not just depression or mental stress. It could be kidney, heart, diabetes, many things. So they help in that way. Kirit, your tips and your comment over the minute before we move to Dr. Rama in India.
Okay, so thank you, and for all our presenters today. I think the key tips is, we need to keep our conversation. We have to talk about mental health in our households, with our communities, our friends. If we don't talk about it, then people will keep it inside, and then there's no solution. Secondly, we heard some fantastic research that we need to get involved with. So that's the key. Our communities don't get involved in clinical trials or research, so our future generations will not benefit. So this is the research that Guru Krishna is going to be doing here in the UK is very much about perinatal mental health, and we need to ensure South Asian women get involved. And finally, it's excellent to see that Healing Our Earth are bringing all these experts, and this is where our turning point is. We can reach out to a number of our experts to find the solutions, to find the lifestyle changes that we need to be able to then help our family and friends. So I'll leave it there.
Thank you, Kirit, and thank you very much. You are a regular producer of the health episodes at Healing Our Earth with your colleague, Dr. Amrita Sharma. Between you two, you co-produce wonderful outreaches, including our Sharon, who brings the American leg over there. And as you say, Kirit, community is very important. And this year's theme was celebrate the power and importance of the community. Let's go to Dr. Ramajayam, who is in India. Your good, best tips that you can give to people that can identify or help them to maybe ease their stress or mental stress. Over to you, Dr. Ramajayam.
Yeah. So the first and foremost thing is talk and listen. So if you are in trouble, please talk. If somebody whom you know they are in trouble, please listen. These two things actually is like almost 50% of the solution. Getting them to talk itself takes a lot of time for you, a lot of understanding for you. So that's the first thing. The second important thing is when you are consulting somebody who is a Western medicine expert, especially in the current scenario, make sure that they give enough time to listen to you, particularly in psychiatry. Because psychiatry still they don't rely on any kind of diagnostic test. This is the only field which rely till now only on symptoms. Unlike other experts who just take few minutes to look into the test and then give some diagnosis, in psychiatry, if you are getting some consultant who also likes to do like that in just 10-15 minutes, then they are actually not for you. And when you're trying to contact people who are in the complementary medicine side, experts like yoga, meditation, again make sure that you are not getting trapped into any kind of cult. Do they have any kind of scientific backup for whatever the cultural practices they are prescribing to you. The third most important thing is, again, it's connected to society and then stigma or community kind of thing. Never get stuck with this question: what if the neighbor or my friend or my family people, somebody knows I'm taking some kind of mental health related medicines, or I'm consulting some counselor or psychiatrist? Because we proudly say that I'm actually taking insulin, I'm taking medicine for diabetes, for hypertension, and that too, we are actually willing to take that even for lifelong. But when it comes to mental health, we are so rigid, we are still stuck with stigma. So if you can come out of this question, what he or she might think that I am having some mental health related issues if they get to know, or I'm taking some kind of psychiatric medicines. Kindly get rid of this question. This will actually solve almost 90% of the stigma related problems, because you cannot change the society, but at least you can change yourself. So these are the 3 points, tips which I would like to give for the audience.
Thank you, Dr. Rama. So he said very simply, if you feel you are stressed or you feel you are depressed, then talk to somebody. And at the other end, if you are the listener, patiently listen to them, don't judge, and don't rush them. Give them time to talk it over. It will help. Sometimes just talking to people helps. And you may not even get there. Just by talking, you might relieve your stress or your what you feel might be mental depression. Let's ask our surgeon Anukul Goswami from his way. What are your tips, Anukul, that may help people who might be facing depression or stress or equivalent?
Well, in my general understanding, thank you. My general understanding is the idea of stress is very, very widespread. It is not as little as people might think. It is actually prevalent very widely amongst many people. It's a question of how they manifest it and how they can, what they call, face it. My general way of understanding it is, first of all, the person can say that I'm undergoing stress, but many of them say that they are pretty tough. They don't want to say that, but usually their relatives and their friends can come and say that his behavior has become abnormal. He's not his own self. He's too much focused into something else, or tends to divert, or not completing his work, or something like that. A small child or an adolescent child will say he'll not want to go and study. He's trying to do something because he doesn't want to get into that kind of stressful situation. In reality, I tend to listen to the person who has got the problem, but I tend to talk much more to the various people who are him or her, to figure out what exactly is going on and what behavioral changes are happening. So I think we have to listen to everybody and not to make any judgment about anyone. Listen to it, understand it, and then figure out what exactly not needs to be done. Because psychological factors is not only biological, but it's also social and psychological and social and community-based issues. You got to address various things together. You also have to see whether what type of community they come from, what is the religious background, what is their thought processes, how much of there are many things actually involved in the process. So when it comes to my own clinical experience, just sit and talk to them as long as I can, and if possible, at the end of the clinical day, I say, do one thing. Once my clinic is over and I'm not under any pressure about finishing my going to the next patient, just come at the end of the day and we'll sit and talk it out. And that's what I tend to do for most of them. And then I get much better information, not exactly about in terms of treating, but at least to understand what situation is. Then I take advantage. Then I take what they call assistance of the social services, psychologists, psychiatrists, everybody who I can. But let me tell it like this: it's not easy to get the support of the psychiatrists or psychologists. They are very rare, very difficult to get their time, and very often in the NHS, patients are put on a conveyor belt and sort of get over with the clinics fast. That's not a good way of treating patients.
Thank you, Surgeon Goswami, who is in United Kingdom. So he was talking about the UK style, what may be available. One of the point, and he reiterated what Dr. Ramajayam said, that if you visit an expert in mental health or a psychiatrist, and if he gives you a solution in 15 minutes, chances are they have not understood you, because it's not simple just like other diseases or ailments. This takes longer time to understand why you have reached to the state that you have reached. So be patient, talk it out. If you are a listener, listen very well. Again, don't judge people. So we are all going in a similar direction. And it's wonderful to know that we are heading in the right direction. Hopefully, at Healing Our Earth, we are empowering community and society. Let's go to our another expert, our senior admin and a senior anchor there in India. We take her comment, then we go and chit chat with our Sharon. And one of the guests today is Eleni, and her topic is quite important as well: emotional alchemy, transforming grief and anger through shadow work. Sharon will tell us more with Eleni. So, Amrita, we come to you. What are your tips and what have you learned today with our different experts? And then we move out to Sharon. Over to you, Dr. Amrita Sharma in India.
Thank you, Neil Kumar. Thank you so much. It's very interesting to know about different facts of life and how we behave in life. And I think with the growing AI, the friends have turned from the physical relationship to virtual relationship, where the virtual reality has become the real reality of life. And then lot has been already said about the personal grooming, understanding, as well as I would also say and add upon with all that what Dr. Ramajam had said, and Dr. Raghu and Dr. Anupul had been talking about. It's also very important to give space to yourself. And it's also very important to sometimes take a pause in your life and to talk to yourself and understand yourself of why the thing and why the thought process inside you has triggered and what has been the reasons behind. Sometimes when my kids come irritated at home, I really have to undergo a lot of things and insight to make him become very comfortable with me, to understand him and to know from him, from the deep of his heart, what has happened in the school that has triggered this behavior. And similar things happen with all of us. As Dr. Ramajam sir said, problems will never end until unless we find what the problem is and what really the solution is. So to address that, finding out, I also found one more thing. Hobbies are very important in life. I think hobbies give you a line of light to live, because you it ingrain that kind of happiness and pleasure, those activities that will groom you in a better way to fulfill your purpose of life and how you have to move to. And I think these kind of trips are very useful to take out space for yourself, to keep grooming yourself, to have a time of pause, to give an insight on the daily hobbies that you can inculcate. Sometimes people say, oh, I've grown up, I can't make a painting. I've grown up, I can't do all that. I think, again, that is the wall that we have created for ourselves. And who better than Sharon can tell us about her hobby, being a student of Sitara Devi, and the dance being the pleasure of her life, has still continued till the age of 75. Nobody can believe. Sharon, over to you, and then we welcome Eleni. Global Namaste to both of you.
It's funny you mention hobby, because as I was going into my dance career, and people would call it a hobby, and I'd like, what? This is my life. This is my work. This is so anyway, yeah, that word always triggered me, if you want to know. And also the other thing, in speaking about this, as you know, an American in Indian classical dance, and Americans, you know, unless you were had come from India, didn't really know much about it, and they would connect it with like exotic dance, or you know, they would give it this like strange kind of sexual connotation, and I would have to deal with that and set them straight, saying, listen, this is one of the most, I believe, the most sophisticated, the most beautiful, and deep, spiritual, and in terms of as a dance performer, the rhythms and all of the different mudras and everything. It's a science. It's not just some kind of showing off your body. And so I'd have to constantly be teaching them about dance. But let's go now to Eleni. Eleni, my dear friend, is a mystic, a visionary, a teacher, and she has a new Substack that she's doing now with just incredible. I invite you all. She'll tell us about it to check out what she's doing now, because her languaging, her deep knowledge of the feminine, the masculine, and the interplay between is really profound. So global namaste, Eleni dear.
Thank you, sweetheart. I'm honored to be here with everyone and honored that Sharon invited me. I am not an expert. I'm a human being walking this path the best I can. And so as I'm going through my own personal discovery, I am learning how to share what I've been able to explore in the depths of my being. And so when I think about the concept of mental health, it doesn't resonate with me in my journey. What resonates with me is that we, all human beings, are souls, first and foremost. And we've incarnated into these physical bodies with constructs that originate from so many sources, not just our immediate ancestral and generational inheritance, but our soul lineage that goes back countless lifetimes. And so imagine now, here we are walking as these human beings, carrying all of these imprints on so many levels. And of course, in this modern era, it can get so overwhelming. And so how do we deconstruct it? And how do we walk the path, the spiritual path that we're all here walking? And how do we really accomplish what we all want, which is ease and peace and joy and the ability to connect with each other, but not just with the human family, but the big family of life, as my dear friend and teacher, John Milton, always describes, and he's been on the show a few times, and the founder of Way of Nature. It isn't just about the human family. It's about the big family. And sometimes the big family includes the unseen world, the deities, the energies, the dakinis, all of the lineages that we here in Crestone have enormous contact with, because we're blessed with multi-lineage, multi-spiritual family interconnectivity. And Sharon has brought so many of these lineages here to this platform to enrich us. And I happen to be one of those that loves to integrate from all of the lineages. I was born into the Western culture of Christianity, but I recognize the beauty in every faith, every faith. And so my journey is really one about reclaiming myself. And we can call that soul retrieval. We can call it any number of things, but it's a process of really surrendering to the highest truth. What is the highest truth? Because if that truth is impaired, it will cause ripples of disconnection, of pain, of anguish, depression, and all the maladies that are present right now on the planet that we call mental health, but it's really a soul disease. It really is. I have witnessed it within myself, within the close family of beings that I'm connected to. That disconnect is a disconnect from our source, from the source of everything. And it's a soul disease. And so how do we approach it from that perspective? And so I appreciate the work that Carl Jung has given us. His legacy of work is incredible. And it is about shadow work and reclamation of ourselves through what is best described as a descent into the depths of our being, so that we can ascend into the highest realms, but not encumbered, not weighed down by the factors that we have not been willing to look at. And there's a saying that comes from Jung that says, what we resist persists. So whatever we push away, whatever we don't want to see, whatever we deny, whatever we're not willing to encounter, becomes a persistent ache. And that ache grows and grows until it overwhelms us, and until we have emotional and mental and physical breakdown. And so how do we repair these torn fragments of our being? And so I have gone into a process of stripping myself bare. I believe in the initiatory process of descent, as the Christ descended, as many mythological stories have taught us, Inanna being the one that I'm most familiar with, the descent into the underworld, where she stripped herself bare, chakra by chakra, completely bare, and came into the chambers of the underworld, and she met the mirror of her twin soul, her sister, Ereshkigal. And she was the dark mirror of Inanna. And in that mirroring, she was able to meet it with absolute compassion, and then was able to redeem all parts of herself and send back into the upper world, fully redeemed and fully claimed in her light. And so these stories persist throughout all lineages. And so here in this modern era, how can we bring it into a meaningful form? And there's just there's so much complexity to this. For all of you who work on a daily level with such distressing stories of people in collapse, of people really going into delusional patterns, of people with extreme chemical imbalances, those are very difficult cases that I, cannot address. I don't have that expertise. What I can address is in my ordinary normal life, I encounter people's souls with their hurts and their trauma and their despair and whatever they're continuing to meet. And I find that there's these looping patterns. There's that we can call karmic loops. And it's a repeat. It's like, haven't we heard this before? Dear friend, this is a story you've told me at least 100 times. What is the meaning of this story? Why can't we unravel it and get beyond it? And I truly believe it's the avoidance of the shadow work. It's the avoidance of meeting ourselves in our darkest phases, like the dark phases of the moon, and looking at ourselves more clearly and saying, oh, it's a hard work. It's not easy work. It's not easy work to look in the mirror and going, oh, wow. So how do we break these karmic loops, these trauma bonds, these patterns? With absolute compassion for ourselves, with absolute self-love, unconditional, and with a connection to a higher source, our spiritual connection to whatever that is for each of us, God, Goddess, all of it. And that brings me to another aspect of reclamation, and that is walking with nature. Walking with nature is the fastest way to reclaim, because nature heals without inquiry. Nature heals without triggering us. Nature heals in an instant when we connect, when we put our bare feet on the ground. And I've had these opportunities, particularly in relationship with John Milton, who is the authority and expert here about the way of nature. And Sharon has worked with him extensively as well. And I've experienced incredible healing without going into process, without going into analytical dialogue, but just being in stillness. And so that brings me to another aspect of stillness is one of the components of healing. Silence is another component, and it brings to point what I've heard here today about listening. We can't listen if we're talking. We can only listen when we're silent. And so stillness, silence, and then the big one for me recently is spaciousness. And Sharon knows this because these are the 3 refuges of this ancient Tibetan practice that we're collaborating with together. And it's very rich. And spaciousness just came in for me recently. I had a healing crisis with asthma and breathing. And the message that came in was, give it space. And it was like such a simple message. And I said, oh my goodness, that's it. Give the grief space. Give the anger space. Give whatever cruelty has come upon you from others, give it space. Give it so much space that it just begins to dissolve. And then when that charge isn't so present, we can tend to ourselves so much more compassionately. And then we can be available because that energy binds us. It keeps us in this bondage, this prison. And so in our daily walk, I encourage all of us to give space to anything that's troubling us, whether it's our kids, whether it's, within ourselves, negative thought forms, anything, give it space. That's my big message right now. So I will pause there and just hear some reflection.
It's interesting in the spaciousness, what's coming to me is what really helps us feel that spaciousness is our breath. Is to really, we start all our practices with some pranayama, right? To bring us out of that state of chaos in our minds and to bring us into the present moment. And so that breathing, particularly breathing with awareness of bringing in the rainbow light into our breath and through the channels and chakras of our bodies, and then releasing, even, metaphorically, you're just like smoke is coming out of you as you breathe out. So you're allowing yourself to just take that deep breath in and then release the anger, all the kleshas, all the different issues. And there's so many practices. There's the 6 healing sounds in the Taoist and the Qigong practice, where you're actually, because the emotions are connected, of course, with the organs from the Taoist philosophy and acupuncture and all that. And so, for example, if your grief is connected to the lungs, and so there are practices for really deeply feeling that grief, bringing the chi, the shakti, the life force into your lungs and recognizing, thinking in front of you, you see every situation where you're feeling this grief. And then through breathing and visualization, you're letting it go and transmuting it. So there's so many practices and there's so many ways. It's, healing our earth. We're really working to bring all of these ways of healing, these paths of healing, to the world audience, because there's way more than, the last time I went to a Western doctor, they're not even, they just, they take your blood pressure and they hear your heartbeat in your lungs, and then that's it. Then they just want to sit there and talk to you about and stick you on drugs. That's what it seems like. So my path has been very alternative, and it's been very rich in terms of so much learning. And a lot of that I'm planning, as Eleni is working with me on the website for Quantum Chi. And we're going to have a whole section with all of the scientific, or a lot of the scientific research that shows how all of these ancient practices, including Ayurveda, including Qigong and acupuncture and traditional Chinese medicine, etc., can really be of benefit in many different situations, not only problems like cancer or high blood pressure, all that, but your psychological issues, because the grace of these movements, just getting in this concept we call flow, it just really helps the nature of your mind and helps you to release the issues and get into that beautiful sense of grace, effortless grace. It's called Uwe. Yeah. Yeah. But Eleni, what I want to know, how would you define the shadow in the ancient Egyptian traditions? There's there's the heart, and then there's it's called the Ab, the heart, and that's it's very similar in the Tibetan tradition, where the heart is really the center and the source of all. And then there's the Ka, looks like this in the glyphs, and that's the kind of similar to the energy body, the chakra system, etc. And then there's the Kaibit, which is the shadow. And in these rituals in Egypt, it was purifying first the heart, purifying the subtle bodies, and then the most difficult was this shadow. So how would you define the shadow, Eleni?
Well, I just want to acknowledge that Lata has her hand up, and I can address that, or we can go to Lata because I know she's been waiting, whatever you prefer.
Well, let's address that, and then we'll bring Lata in, because I'm sure she has something, as usual, amazing to say.
So what I want to acknowledge is, granted that these ancient traditions have had their own practices, culminating and rising from the energetics on the planet during those times, but we are in new times now. In this modern era of disconnect and technological proliferation, and the ability to, like Amrita said, the ability to just shut out the natural world, the organic world, the interconnectivity with humans, and to go directly to a virtual world of artificial intelligence, that, maybe our ancestors had that sort of connection, but we can appreciate the legacy of what the Egyptians brought. But where we are today, and to address your specific question in regards to the shadow, in our psychological construct, the shadow is simply all the exiled parts that we refuse to look at. All the exile. Think of that word, exile. No, I exile my anger. I exile my judgment. I exile all the projections I make about the world at large and people in my life. I exile it all. I do not acknowledge it. I exile it. We can also refer to it as denial, but I like the word exile because it means we just push it out of what we're, in our conscious awareness, but we can't ignore the unconscious. And that's where the shadow lives. And the unconscious is in that murky place. It comes in our dreams. Sometimes we wake up from dreams and we go, what was that about? Sharon, you had a biggie recently, and so did I. It's the shadow trying to get our attention. It's the exiled parts. And sometimes those exiled parts are inner children, our inner child who was never honored, who was never acknowledged, who was never really met. And so that's an exile part. There are so many aspects of ourselves that we've buried, and they live in the unconscious until they're met. And then when they're met, that is the resurrection. That is the phoenix going into those realms. And not exile parts doesn't mean the bad parts of us. It can mean the most powerful, the most creative, the most glorious parts of us that we've exiled because our mother told us we couldn't sing. Our father ignored us and thought that our pursuit of dance was ridiculous. What are you going to really do for a living in life? So these are all shadows. So how do we celebrate ourselves? We look at ourselves wholeheartedly and we say, okay, what have I exiled truly? And most often it's pieces of ourselves that are beautiful. It's not, we think it's all the bad stuff because that's what the programming said. But no, the unconscious reveals everything. And sometimes we do have to look at the parts of ourselves that have not been kind, that have not been generous, that have not been devotional, that have been self-serving, self-absorbed behavior, selfish ego behavior. Those parts have to be looked at. And those parts are the most difficult because they're stuck in an identity construct, masks worn to protect from revealing those darker aspects of self. But those aspects, if we're truly spiritualized beings, they have to be acknowledged as well. And sometimes we call it out in each other, but the best way to bring it forward is to call it out in oneself. And so that's how I see the shadow.
It's like when you feel something in this buzzword triggering you, instead of reacting, it's like, oh, what is this? Why am I being triggered? What is causing this in me? Not that one, but why am I responding in this way to this situation? Lata. Namaste.
Global namaste, Sharon, and to your guest and everyone else. Yeah, this is also one of my passions, mental health awareness. So, Uncle Bhai, I think that is my passion as well. And I'm, very much lived in experience, I think, has taught me an awful lot of intelligence around the subject and becoming very sensitive to other people's needs. So I love this thing about the shadow as well, because, there's so much to explore and learn. I think the inner child as well that you're talking about is like you said, the touched parts which have been left to just infest, and then it triggers as anger. But it's not your anger, it's the pain and the suffocation of not being addressed. And like you said, when parents don't encourage and support us as well, or it could be our teacher, it could be our husband, it could be our children, it could be anyone that we're connected to. And you can't just cut them off, can you? You've got to learn to deal with them because they're part of you, your identity, your family. And so how do you deal with that is obviously getting more and more educated around this subject. But not everybody's at that level, are they? To understand this, they're on a different spectrum and different degree of understanding and the capacity of really getting into it and diving deep down. Everyone's so at a different level. Not everybody, it can't be the same answer for everyone or the different at the same level. And that's the beauty of it, to understand these concepts. It's only then we become very much more in tune with other people's needs. And then that, of course, helps us to have better relationships with other people, with ourselves, obviously, but also with the other person, and feeling, how to diffuse the situation. And, and obviously there are some things that are far too late, water under the bridge. Those relationships are far long and gone. So, I mean, I just felt it's just fascinating, and I resonated with everything you said, because about the other subject I'm going to come to is connecting with nature. Yesterday I was in a beautiful suburb gardens, the Royal Botanical Gardens of Kew Gardens, which is renowned worldwide, and the amount of trees there, thousands of trees, and it was just so amazing. You know, just being there, the atmosphere is truly divine. And then you touch those trees and you can see they've been there for thousands of years, and they were solid, and the energy from there, it's just emancipating there, you know. And everyone was so calm, tranquil, at peace, and it was just wonderful to be mingling with these guys, you know. And walking barefoot was one of the things I managed to do, and it really does transperse the negative energy. And when I came home, I just had to go and wash it off, because I could feel this negative energy. It had to come out, and it was amazing, you know, how it's so powerful, it's so invisible because we can't see it, but we feel this thing and it talks to you. But it's so silent, isn't it, most of the time? And so you really have to pause and be in tune with them. So it's amazing the way we reach our different levels. The more we do this work, the more higher we seem to get, and more deeper we can go into ourselves. And this is where I find it so fascinating with what let me see the name, Eleni said. I just loved every word that you brought up, and also the previous guests. I could understand everything that they were relating to. It was marvelous. It's just amazing how we all are in need of counseling and therapy, and everyone is at a different level, but we mustn't misdiagnose them. That's the problem. Sometimes you can give them the wrong tablets or misdiagnose them, and then expect them to react in a certain way. Well, if they give it the wrong medication, they're not going to perform, and they're not going to get the healing or the, you know, recovery process. So it's all very, very complex and very so sensitive, and we need to be in tune with one another, because everyone's so different. Sharon, you're different to Eleni, and I'm different to Meeta and Lakshmi and Uncle. So it's just so wonderful, isn't it, how we're so individual, and there's beautiful parts to all of us. I don't know what you have to say about that, Eleni or Sharon.
I would love to speak to that. Thank you so much, Lata. What you said just really touched my heart. And as you were describing your experience in the gardens, all I could think of was, oh, I wish I was there. And the richness of the trees are so reverent and sacred, and we must do everything possible to protect them from we know any level of abuse or attack towards our trees is unforgivable. So I'm planting that as a seed, because I know that the world right now is in a crisis, and we can't minimize that. We can't minimize the environmental desecration, which is a desecration to the sacredness of all life. And so I just want to honor what you said, and to touch on yes, we're all so unique. We're all so different. Each of us is a soul signature from the divine. Every single one of us. When we say namaste, we are bowing to that divinity. I bow to the divinity of the trees and the animals and the stones and the rocks. I bow to all of that divinity. It's all divine. And yet, how did we get to this place today in our modern era, where we are disconnected from that sacredness. And I just to ponder, we can't possibly solve all the problems of the world here today, but we can begin with this dialogue to begin to cultivate not only our personal practice, which is what Sharon was speaking to, which is absolutely essential. And I can validate that from my own personal experience, but just to validate each other's pain. We all have our different burdens, so many burdens. And how do we let go? How do we support? I think it's by holding space. When a friend comes, or even a stranger, and we can hold space, and we can look at them compassionately and say, I see you. I recognize you. I bow to your divinity. There is this light that comes in, especially among children, who I think are being completely ignored and invalidated. And whoever, those of us who are around young children, I know Sharon has two beautiful granddaughters, and the joy that is sparked in them, and the joy that they can create in instantaneously, because they recognize the spontaneity of life is always present. And Sharon brought the concept of Wu Wei, which is a Taoist term that means effortless action, effortless joy. Children are born with it. And what happens is it's stripped away from them. It's stripped away from them piece by piece. I think we need to restore that childhood innocence in everybody and bring back that incredible, organic, effortless joy that keeps bubbling. Because why not? We have a short lifespan. Why not enjoy it?
Neil, you asked for advice. I would say one of the best things to do is to limit your television. Watching the news, limit the news, because I know too many people in this chaotic political atmosphere of the world who are completely addicted. Rather than go out in nature, they're glued to the TV. They're glued, and I can see how the negative, the news is so much about just the clickbait, what kind of weird, horrible thing will get more people watching. And we need to really let go of that. And as individuals, what can we do? We can be here on Healing Our Earth. We can do everything in our power to help, to counter that negative energy coming at us, and to see the beauty in everyone and everything of our amazing planet and our amazing heritage.
I think also that news watching is mainly a male thing. They really love the newspapers and the news. Oh, I must watch news at 9 o'clock. They come home and they want to watch. So I think, whereas I've stopped watching news and newspapers for decades. I just cut it out of my life, even the television. So that in itself helped me to cleanse the mind out from fear.
Yeah.
Otherwise, I think I would have been a nervous wreck. And I could see with clarity if the doctors wanted to prescribe me things, I would say no. And I think to keep news out is one thing I would agree. It just contaminates the brain. You can't see the black for the white, and it just distorts everything, because then you're allowing your mind to be controlled by the media.
Yeah, I want to add something to what Sharon layered in, because it's so important, and it's just the whole concept of addiction, and addiction is such a huge part of the shadow it's an avoidance. It's a defense mechanism. We become addicted to the news because we want to avoid our own personal work. We're distracted by what's happening out there instead of what's really important, what's happening in here, because that's what is most in our daily life, what is most at stake. And as someone who was addicted to the news, and as someone who's recovered from that for a while now, I understand what that hook is. It's a hook, okay? Things hook us. Everybody's different. Everybody has different hooks. And to liberate and emancipate, as Lata has suggested, requires deep self-examination and a real deep questioning of, is this what I value? Is this what I want to bring into my field? Fear and negativity and anger and fighting and polarization? No. My answer today is no. And so I won't engage with it. Sometimes, it comes in my field when somebody says, hey, did you hear about? No, I didn't hear about it. Tell me. But I stay in this neutrality of don't come into my field, don't poison what I've created, don't contaminate, we haven't talked about toxicity of other people, toxicity of aspects of our own sabotaging inner dialogue. There's so many toxic elements that are coming at us. No wonder we have a mental health crisis in the world. No wonder. How do we clear toxicity? Because the planet needs our support for the toxicity we've caused environmentally. But what about our personal environments? And watching news is the most toxic thing you can do, aside from eating poisonous food and taking horrible drugs, and then doing other things, which I won't mention now, that we all know. There are dark side stuff, all toxic. So let's just make a commitment to be pure channels. And to be pure channels, we don't let any more toxicity in, and we clean up the toxicity that has already come in. And we do that faithfully and with absolute self-compassion and love.
Thank you. Thank you, Eleni. Sharon, let's take a quick comment from Mita. Then we tell people what's happening over the next 4 weeks. And then we will wind down. So Mita, your comment, and then we show people what's happening over the next 4 weeks.
Global Namaste, everyone. Thank you, Neil. Yeah, it's very interesting topic because mental health is such a tip of the iceberg. People don't see if you are broken mentally. They can see if you are hurt physically. You don't see how it affects, because the mind controls the body as well. So how it completely crushes you, only if you've experienced from a near and dear one, you will know the difference. So it's such an important topic. I work in the pastoral care of higher education, university, and we have a wonderful provision. We have excellent team of counselors, and we have many of the provisions. I was writing in the chat as well. We have an artificial lake. You can go and sit near the lake. It looks like real lake. And the water feature with the ducks and with the stillness of water completely changes the paradigm, especially watching sunset over there. The 5th floor of the library is famous for PhD students, but it's famous for sunrise as well. So those who are working all night will see the sun rising. And it's so all these little things which are for free, which can keep our mental health, in good shape. We should make the most of it, I would say. I mean, between the counselors and the pastoral care department where I work in the Religious Life and Belief Center, we bounce back the staff and the students. If we think they need to go to a qualified counselor, we send them there. If they think they need some pastoral care with reference to religion and culture, they are bounced back to us. So we have that, understanding. And irrespective of religion, we go and see anyone. I was approached by the director of Wellbeing and Welfare Center for Wellbeing. The Mita, can you look after this Muslim student who was a foundation student? And I looked after her for nearly 3 months. She was hospitalized and she was under Section 2. She couldn't even go out. So, and recently her dad called me as well. So you build up a relationship as well, because those who are not understood of what they are going through, and you are there to just listen to them. Sometimes they just want to be listened, and without any judgment, without giving any advice, because we find our own solutions. We have that inner divine capacity. As Eleni was saying, we should be like children. We should be we should be so transparent, so happy, so much living in the moment, and things will not bother us, as much as if we keep on thinking about, oh, this is a problem and this is a problem. Either it is past or it's the future. So yeah, so thank you very much for having this wonderful program. And I think mental health is utmost necessary in today's world, because our mind is not built to deal with the kind of stresses we deal every day. We are not built for that, and we are facing that, and we are facing as if we are in the caveman mentality, still fight or flight, and we don't know what to do with it, no matter how much we read, but the natural response will be different. So it's very important to have this kind of provision on a global level, where everyone can contribute, everyone can understand, and this goes in the archives as well. We can listen to it in future, and we before it becomes unsolvable disease, it has to be given good attention. NHS, National Health Service, does wonderful program on mental health and spirituality, and I get I get invited to train as well, which again we do on an honorary basis. But they also want to understand from a spiritual side, from a religious side, what are the factors, everything. Pastors from Christianity, they explain about the superstition in every different religions as well, how that might affect. So how mental health can be good, spirituality can be good in some ways, cannot be good in some ways, religion especially. And all those things play a huge part, and perhaps in future we can embrace that part of it as well in this episode. I think I have spoken a lot, so thank you very much for giving me the opportunity, and lovely to be on this program. And thanks again, Neil, for giving me.
Thank you, Mita. Thank you. And a quick comment from Dr. Lakshmi Vyas. Make it quick, please. And then we go to our next 4 events. Dr. Lakshmi Vyas, over to you.
Eleni and Sharon, you came and really elevated the whole discussion to a different level. And I really, really thank both of you for that. And every time you come, you're always there, jubilant. And I wait for you to come, in fact. And thank you very much, Neil Ji, for this wonderful program. It was very informative, and we should have more of these talks. Thank you very much.
Absolutely. And talking about more, Mind, Body, and Conscience Conference is also taking place. So let's share with people the 3 episodes that's coming on healing, and one that is happening live in IIT Monday over there. So Sharon, well, one of the episodes that you like is next week.
Yoga and meditation for body, mind, and soul. Join us for this free global online session, Sunday, 25th of May, 2025.
And Sharon, you also got one of the slot at 10:30 MT. So if you just reply to the group in the Telegram. And the next one, Amrita, tell us more about this.
So the next week to that is Cancer Care and Awareness episode, where we will be bringing cancer survivors and talking about their experiences and knowing more insight on that, which will be broadcasted to you on 1st of June, 2025 from 2 p.m. British Summer Time.
So if you know anybody who is suffering from cancer or who has survived with cancer or knows cancer awareness or any oncologist, then do connect to us in our Telegram health group and we can bring them to give us the tips. And this one, Amrita, is very close to your heart, and Anukul, Surgeon Anukul, who is here, and other speakers who were earlier, actually going to India in person. And isn't this wonderful? It's a second international conference, MBCC. So it's Mind, Brain, and Consciousness Conference, which is taking place in Himachal Pradesh, where Dr. Amrita Sharma is normally, and it's Indian Institute of Technology. And this is taking place between 4th and 7th June in person. And the themes that are actually involved in this episode is so beautiful. It's got so many variety: music, Indian performing arts, Ayurveda, Indian philosophy, science of consciousness, neuroscience, theories of perception, quantum perception, cognitive psychology, cognitive biomarkers, science of intelligence, sleep and dream studies. You can't apply anymore because it's already finished, but look at the speakers. Some of the most eminent speakers in the industry will be flying to Himachal Pradesh. Isn't that wonderful, Amrita? You're looking forward to it because you're part of it.
Yeah, yeah. And I would love to invite Sharon, Eleni, Dr. Lakshmi, Meeta ji, and Lata ji next time for this conference, definitely. And Sharon's dance. And of course, Neil Kumar, without him, it will be very incomplete. Okay, let's go further for our next episode, on which will be broadcasted on 8th of June. And because on 5th of June, we have World Environment Day. So we are celebrating World Environment Day, our land, our future, and we are the generation for the restoration of this time. So this is what we'll be bringing to you all. And we look forward for more and more from you all. Today's episode, as usual, was again a beautiful one because of our episode producer, Kirit Mistry. Without him, this episode was incomplete, as well as the panelists, the experts. Thank you so much for joining this episode. And a special thanks to Sharon, Eleni, Dr. Anupul has been from the very way morning till now. So, and Judith as well. Let's wind up with a short Gayatri mantra. Om Om Bhurbhuva Swaha Tatsavitrvarenyam Dhीमहि धियो यो न प्रचोदयात् Om Swaha Tatsavitrvarenyam Devasya Dhimahi धियो यो न प्रचोदयात् Om Swaha Tatsavitrvarenyam Devasya Dhimahi धियो